Welcome to the Implement This Pre-Con. We are so excited for today. We're going to all learn a lot about implementation science. A big thanks to Colleen Kalishu, our fearless leader, for helping us pull all of this together. I'm Miranda Hallquist, and I'll be moderating today and introducing the speakers as they go. So first, a couple of introductions. We're going to introduce the speakers throughout the afternoon, like I said. We also are really encouraging everybody to single task today. So we have a lot of moving pieces in terms of speakers and table activities. And I think you'll get the most out of the symposium today if you aren't popping around to your emails on your computer, for example, which will be tempting, I think, for all of us. But single tasking is encouraged. You probably all saw you walked past the restrooms. They're right out to the right and around the corner. If you need to use them, feel free to get up and move around throughout the day. The outline for our sessions today is that we'll start with some didactic content and then have some time for individual reflection. There'll be facilitated discussions at each of your tables. And then we'll have example projects presented with each section of didactic content and reflection. So in terms of the outline for the topics we'll be covering, we'll start with what is implementation science, or IS? How can IS be applied in genetic counseling contexts? What is the REAIM framework, which is one of the implementation science frameworks? And how can IS be leveraged for DEIB goals, diversity, equity, inclusion, and belonging? There'll be a break from 2:25, half an hour break starting at 2:25. The goal of the individual reflection is not to have the right answer or the final answer or the perfect answer, but to get yourself thinking about whatever is coming to mind around the symposium and the topics. Case in point, we asked you to start working on activity 1 when you came in, and potentially you wondered if you didn't know all the language for activity 1 and you're like, what's the definition of this term here? Or I don't really know how this applies to my project. All will become more clear across the course of the afternoon, so just jot down ideas as they come to you. Don't worry about full sentences or right answers. We hope that you use this as a workshopping opportunity and making connections this afternoon with folks who will be able to continue to help on IS projects into the future. To give you a quick overview of all of the different people that are here today, you've already met me, your moderator. We will also have a number of example project opportunities where example projects are going to be presented throughout the afternoon to illustrate concepts within a particular project, and those are going to be presented by Cindy James and Colleen Kalishu, who I'll introduce in a minute. We'll have expert consultants that are wandering around the room ready to help. Expert consultants, can you give a wave? If you have questions at your table that you would like some expert advice on, they are here for you. And finally, at each of your tables, we have a facilitator. Can the facilitators at the tables give me a wave as well? Hi, everyone. Excellent. So facilitators are there to help facilitate the completion of the activities and also help call over consultants if needed. So without further ado, we're going to jump into our research project examples. I'm just going to introduce both Colleen and Cindy before we get started. So Cindy is your project first. I'll introduce Cindy first. Cindy James is an associate professor of medicine and cardiology and genetic medicine and a certified genetic counselor at Johns Hopkins University, and is the research director of the Johns Hopkins Center for Inherited Heart Diseases. And Colleen Kalishu is the Senior Director of Clinical Research at Genome Medical, a genome health and technology company that provides scaled and remote genomic services and technology, and she leads Genome Medical's research efforts, which focus on innovation and scaling in the delivery of genomic medicine. And I forgot, I also have an introduction for all of you, almost late breaking. 29 of you responded to our poll that we sent out in advance asking you to describe some of your interests and reasons for coming. So of the 29 of you who responded to our poll, 45% practice in a clinical setting, 38% in research, and 17% in a lab setting. When asked to rank on a 1 to 10 scale, 1 being the least and 10 being the most, your expertise in implementation science, 35% of you said 1, so low, and 97% of you answered 5 or below. On the same 1 to 10 scale, we asked about implementation science comfortability. How comfortable are you using implementation science frameworks and such? Again, 41% of you answered a number 1, and 93% of you said 5 or below. When asked your primary reason for joining, 48% of you said you were interested in wanted to learn more, and 35% said that you have a project in development and want to improve, and we hope that you leave here today with that improvements or adjustment. And finally, 55% of you said that you have made changes in your lab, clinical practice, or other, and measured the outcome or impact. So I will say to those of you who said you are a 1 on the scale, if you have made changes and measured the outcome and impact, you are further along than you think. And with that, let's get started on our example research projects.
Hi, good afternoon, everybody. I'm Cindy James, and I'm just so excited to be here. I'm so thrilled that you all are here to work with all of us together to learn or get better at what is, for me at least, a new form of research. So I'm up here not as an expert. I am right there with you all as a 3 on implementation science. And the goal is for me to present a research project today that we will show development through the course of the morning or the course of the afternoon, and how we might be able to apply an implementation science framework to it. So with no further ado, I don't have any conflicts of interest to disclose. I have spent my career in cardiovascular genetics and genetic counseling at Johns Hopkins. And starting a couple of years ago, we had 2 problems with our genetic counseling service delivery in the cardiovascular space. Problem 1 was that our primary cardiac outpatient genetic counseling service delivery model, which was standard pretest counseling with results often returned by phone or EMR or sometimes a quick in-person visit, wasn't really working very well for us. The counselors were spending a lot of time on education, discussing hypothetical results. We weren't really sure this made a whole lot of sense for counseling adults that were increasingly seeking guideline-recommended, genome-guided cardiovascular care. And we wondered whether a post-test focused genetic counseling service delivery model could improve both patient outcomes, including both psychosocial and medical outcomes, and genetic counseling efficiency. All right, that was problem 1. Problem 2 was in the inpatient space. Our inpatient genetic counseling was inefficient. We could fulfill only the most urgent consults. The billing was problematic. Our counselors were stressed. The referring physicians are unhappy. And, probably most importantly, our patients with clinically indicated genetic testing weren't getting it and certainly weren't showing up for genetic counseling. So our second problem was, well, could we rethink this inpatient service delivery to address these many issues? So, problem 1, we approached, and I'm going to go through this quickly, by writing a grant to NIH, got a grant for a 3-arm randomized clinical trial to study shifting the primary genetic counseling outcomes session post-test. And the measures for that are change in patient empowerment and engagement, psychosocial impact of genetic testing, cardiovascular adherence with medical recommendations, and genetic counseling efficiency, which we operationalize as time. Like I said, 3-arm randomized clinical trial, usual care versus an efficiency arm and a flipped arm, both of which replace pre-test genetic education by a genetic counselor with an educational video. So why am I telling you about this? This is not implementation science. I'm introducing it partly to give you a sense of where I come from, because that'll play out later, but perhaps most importantly, because if we were going to do pre-test education by video, that of course meant we developed these pre-test educational videos. They involve panel testing and family-specific variant testing for lipids, as well as a pair of videos for cardiomyopathy and arrhythmia. And these videos, we've done summary formative evaluation. They're working well in our clinical trial, education. level, at least as measured by the cardiovascular MMIC knowledge scale, is good. And so, with problem 1 under control, we started to think about problem 2, our inpatient problem again, which was only getting worse. And instead reframed it as, okay, so can we rethink this inpatient service delivery to address these many issues? And giving credit where credit is due, my colleagues came up, said to us, Crystal Tishnell said, you know, we have these tools, we have this experience, we're using it outpatient, can we move it inpatient? So our new question was, can we leverage our outpatient post-test counseling trial experience, patient feedback, and successful videos to develop and test a point-of-care genetic testing implementation strategy with post-test genetic counseling to help solve those inpatient problems that hopefully will be generalizable to other cardiovascular settings? I will say, we hope this is implementation science, or at least the frame of it. And the other thing I should acknowledge is another one of my colleagues, Emily Brown, took this idea, ran with it, and actually, we just found out a couple weeks ago, was awarded the full member JEMF award for this project. So what we're going to see the rest of today are my thoughts as we develop this project, because of course we had no idea Emily would be funded. But you'll hear more about this on Friday as well. So thank you.
Hi, everybody. Super excited to see you all here. I will kind of reemphasize part of what's been said before, which is Cindy and I are really here as your fellow learners. I have never done an implementation science project. I attended the EBS last year. That's all I know. But I've quickly realized that a lot of the research I've been doing in the last few years could be implementation science, or could be improved by application of implementation science methods. So we're gonna show you kind of what some of our learning has been. So my disclosure is the employment and ownership interest at Genome Medical. Now, while I lead up research at Genome Medical, and a lot of my career has been in research, the intent with this project example is to focus more on those of you who maybe are just making a change in your clinical or laboratory practice. This one is a clinical example where you aren't going to get an IRB, you're not going to be consenting people, you probably have a lot of constraints around what you can do and what you can measure. It's a change that you're applying to everyone. You'll learn later with Alana about kind of the, with Debbie, pardon me, about the differences but also overlap between research and quality improvement projects when it comes to implementation science. But this one is intended to be kind of for those of you who are doing a more practical change. So what was our goal? There's also some overlap between what Cindy and I are working on, because these are questions that are really happening a lot in our field right now. They're all over the posters this year, which is how do we increase efficiency? How do we decrease repetitive routine tasks for genetic counselors? How do we increase access, get more people in with the same amount of genetic counselor time? So at Genome Medical, we wanted to do all of those things. We're doing this across a few specialties, but today we'll be talking about hereditary cancer. You'll be learning in a minute what the thing is in implementation science, but basically the change we want to make in our counseling practice is that the patients will engage with a digital education tool before their pre-test oncology visit. And then because they've had that education in the pre-test oncology visit, the counseling will be revised to involve less education. So that's the practice change that we want to make. To tell you a little bit about our digital education tool, it's called the RISE Hereditary Cancer Education Module. It takes 5 to 10 minutes. It's designed by genetic counselors. It's patient self-administered. It can be texted to them. They can access it via QR code. There's a variety of ways they can get to it. It is video-based. It's also interactive. So there's like a tell me more for people who want to get more details. We also have some preliminary data on our education tool. We've seen a high uptake rate and a high completion rate. We've got some patient feedback, and they rate it highly on ease of use, ease of fitting into their day, and it being helpful. I've got a QR code up there. We actually have a few posters on this that we'd love for you to come see. And we recently won an award for this education tool. The other thing that is increasingly clear in the literature is that this type of tool for educating patients tends to work. So conveniently, this systematic review just came out earlier this year, and across a variety of outcomes of interest, the educational tools like this, varying in format, have been shown to be effective. So where are we doing it? What's our context? So we are a large nationwide genetic counseling company. You're going to be learning some of these terms in the next talk, but I'm just getting your brain primed. The adopters, the people who will choose that we're going to take on this change, are our clinical leadership. At this point in time, when I'm talking with you, they've already made this decision that they want to make this change. The patients who will be receiving it are our patients referred for pretest cancer genetic counseling. And then the people who will be implementing the change, you're going to learn about that more in a minute, are the folks who are deciding how we deliver the tool, and then the genetic counselors who are actually changing their counseling. As often happens when we're making changes in our laboratory or clinical work, we have constraints. We have a pretty quick timeline. There's actually a meeting this week to turn this on while I'm still sitting here talking to you all. We want the change done and the data measured by the end of the year. Constraints that are probably common to many of us when we're trying to make changes in our practice are we can't necessarily get all the data we want. So, I've done a lot of research studies, prospective, cross-sectional, where we're thinking carefully about what we want to measure and picking our validated measures and piloting our questionnaires and whatnot. This is none of that. This is mostly 90% of what we're going to use to measure whether this worked is data that's already routinely collected. Examples of which I have up here, and I can probably get some leeway to squeeze in a couple other questions, but not in a consented survey kind of fashion, more adding them to existing parts of the patient experience and workflow. So we tried this a little over a year ago. We did a pilot. We were intentionally doing it a pilot, and we learned some things. First of all, at the very beginning, we had what we felt was quite low uptake of the digital tool. Of the people we sent it to, only 30% were starting it. So then we tweaked the content of the text message that sent it to them, and we over doubled that, which was great. The completion rate was great. 89% of patients who started it were completing it. What I now know from what I've been learning from my colleagues who will be speaking to you today as we've been preparing for this is this was about implementation. Getting the content of that text message improved so that we did double the uptake rate was really a question of implementation methods. The other thing that we learned was that most of our genetic counselors didn't really make the practice change. They didn't revise their counseling. And we learned from them directly why this was the case. The way we set up our pilot was that these patients were actually a pretty small percentage of their weekly volume. We have a very high volume practice that relies heavily on technology and genetic counseling assistance, so the GCs are already practicing at the top of their scope, and most of their clinical time by far is seeing patients. But because our pilot was small, the number of these patients they saw a week was small, which made it hard to change their practice. Some of our genetic counselors had concerns that the patient didn't understand the information well enough, and there was some hesitancy to change counseling as well. We also had some issues with the implementation where it wasn't easy for the genetic counselors to easily see if the patients had done the digital tool. So this is actually largely about implementation too, as I am learning. So in our pilot, was our intervention, our practice change effective? I have no idea, because we didn't actually get to measure our outcomes because the change didn't actually happen. And that's why I'm here, is to learn alongside you about how we could have done that better now that we're going to do it again, and how we can leverage implementation science approaches so that we can get it implemented well enough to measure whether it works.
So in a minute, we'll be pointing you towards activity 1 to work through. I have a couple of orientation things I want to wrap up before we get there. First, if you would like printouts of the materials rather than using the app or the PDFs we sent in advance, there are printouts available up front. Feel free to come grab the resource sheet or anything else, the worksheets that you'll be working through. If you'd rather handwrite, jot notes that way, those are here for you. Secondly, there is going to be a Q&A time at the end of each of the didactic talks, and there are a couple of ways that you can ask questions. We're hoping that these are more kind of clarifying questions of the ideas that were presented in the didactic talks. There will be a panel at the end that's more for discussion of ideas and research projects and elaborating on things. So if you have questions after any of the didactic talks, you can either submit questions through our Q&A online. I'm going to put the QR code back up for that while you all are working on activity 1. Or you can come up to the microphone, or we can bring a microphone around to some of the tables. So 2 different ways: ask in real time, submit. I'll be monitoring the Q&A. If you're feeling like, oh, now that we've heard about a research implementation science and a QI implementation science, I might be at the wrong table. No harm, no foul. If you feel like you'd like to change tables, now's the time. Now's the best time, because after we sort out tables, we're going to ask you to introduce yourself, meet your facilitator, talk a little bit about what sparked your interest in attending the symposium, and start working through those questions in activity 1. I'll remind you again that some of the language in activity 1 we're going to define in Debbie's talk, which comes after activity 1, but we'll get there and you'll sort it out. So without further ado, change tables if you'd like, hang out with your facilitators, and I'm going to put that QR code back up for the online question submission. coming back to you all early because I understand that many of your questions are actually answered in Debbie's talk. So I'm going to interrupt your lovely conversations. We're going to let Debbie talk, and then we're going to give you this 10 minutes back at the end of her talk so that hopefully you'll have some of those common questions answered. And then, like I said, you'll have a little more time for activity 1 discussions after she talks. So my cheat sheet for introductions. Debbie Cragen is the director of the Genetic Counseling Graduate Program at the University of South Florida, where she also conducts research. She has worked on several NIH grants related to dissemination and implementation research and has done a lot of other great things. I should have said earlier, I have cut the intros down to 2 sentences apiece. Everybody who's talking today has a much longer bio than I'm saying out loud, so if you want to learn more about anyone, you can find that detail in the app. The other 2 pieces of information I want to provide. We're working on getting more written copies. We're so excited that you all are engaged in this and you want to be writing hand notes. We're working on getting more written copies of the worksheet. And you'll all have noticed a green card at your tables. Those are to raise if you want to flag down a consultant to come help. So without further ado, we'll get to Debbie's talk.
Okay, I'm really excited to see all of these people who are here for implementation science. I wasn't sure if we'd have 5 or how many we'd have. So I want to disclose that I am very much in favor of using implementation science, but otherwise I have no conflicts of interest. And as you already heard, part of the reason why we think genetic counselors are going to be very involved in this in the future is because we have a lot of innovations that we're going to be starting in our clinics or already are. And as we do that, I think it's valuable to have some of this structure to understand, hey, people study some of these types of things. You're not alone. You have some background for that. So I want you to think about it. It's not a poll or anything, but I want you to think, if a new tool doesn't improve patient outcomes, it usually means that it's ineffective and should just be discontinued. Anybody want to say true? Anybody want to say false? Anybody don't know? See, so you guys already know a lot about implementation science. Yes, it is false. It could mean other things as well. It could mean that your recipients or end users are just different in some way. Different patients, as we know, may require different tools or some added support, or the tool may need to be adapted. A very simplistic approach to this is, say we have Spanish speakers. That tool that was in English is not going to work for those individuals, so things need to be adapted. It could also mean that the tool was not implemented as it was intended, and this is an implementation failure. So why can implementation fail? It can be for several reasons. It can be due to lack of fidelity to the intervention, meaning maybe it just was not even completed by the individuals, the end users, or maybe there was too low of a dose, meaning there was insufficient time spent, or there could have been modifications to the core intervention components, and when we modify things, they just may not work the same. It could also mean that there are new or different real-world barriers that arose that didn't arise when it was tested somewhere else. So we talk a lot about contextual factors in implementation science, and contextual factors can be all sorts of different things. So if you have variability in resources across different sites, or variability in the leadership support, or variability in the people who implement it, if some individuals who implement it are very gung-ho and others are not, that could make a big difference in whether your implementation works. And it could also make a difference in terms of whether it fails. So in real-world settings, we know that healthcare and outcomes are inequitable. And there are some evidence-based practices that are just not feasible or not acceptable or maybe not even appropriate for all settings. So we do sometimes have to adapt things. And this also explains why a lot of our evidence-based practices are modified or just not even adopted at all. And implementation science helps us understand how to make something work in different real-world contexts. So what is the thing we're talking about in implementation science? Usually in implementation science, we're talking about an innovation or an intervention and evidence-based practice. So we really like to have some evidence to support something before we go and spread it and implement it all over. But one of the things I want you to think about throughout today is a quote by Larry Green. If we want more evidence-based practice, we need more practice-based evidence, and that's where all of you come in. Implementation science can help you with this because it helps us understand why a thing did or did not work, why a thing may have worked for some people but not others. Also, it helps us understand how to increase the chance that the thing will work in new contexts to begin with. One of the things I like to think about is even if we have a thing that is 100% effective in our clinical trials, whether it impacts anything really depends on whether it's adopted and whether or not people implement it with fidelity. So if we think about it, if only 10% of clinicians adopt the thing, and if they only complete the thing 50% of the time, now our impact is down to 5%. So implementation science is the scientific study of methods to promote the systematic and successful use of something in routine practice. And the ultimate goal of implementation science is to improve the quality and effectiveness of health services in order to improve patient outcomes. Now you may be thinking, well, what's the difference between implementation science and quality improvement? And as you can see, I just snuck up the goal of quality improvement and it's the same. So they do have the same ultimate goals. But quality improvement is often defined as a systematic approach to improving care by implementing a thing into a specific setting. There is a lot of overlap. But what is the thing when we're talking about quality improvement? The thing is often a little bit different, but not always. We'll talk about that. The thing is a process improvement or a practice change. And actually, the things can look very similar in implementation science and in quality improvement. So they might be more like these things. When we're talking about implementation science, where we begin is a little bit different than when we're talking about quality improvement. We start with the intervention or the evidence-based practice when we're talking about implementation science usually. And with quality improvement, we start with a problem and we make a process improvement or a practice change to try to help address that problem. So you can see here we have our evidence-based practice versus something we do to solve a problem. We have additional goals for these, and for implementation science, one of the goals is to develop more generalizable knowledge so that we can implement things even better in the future, or quicker in the future, or more successfully. And we want things to apply to other things or settings when we're talking about implementation science. Whereas usually in quality improvement, we're really focused on local processes and systems, and the goal is not to generalize to other things or other settings. The approach can be a bit different as well. I think one of the things that quality improvement can really benefit from implementation science is the use of theory and evidence when they're selecting what might work to begin with. But usually in quality improvement, there's this rapid cycling of trying things and seeing what might work. The importance of theories, models, and frameworks, we're going to learn about one we've talked about is REAIM. But these really help to provide an explanation for why an intervention works or not. They can ensure critical components are evaluated. They can increase the quality and effectiveness of the innovation. And the last thing that I want to talk about is the outcomes that are measured are a little bit different, though there are some overlap when we're talking about implementation science and quality improvement. So let's talk about that a little bit. I have a conceptual model here. Implementation science is full of them. I really do feel like this one helps a lot to understand some of the differences in what we're measuring. So when we're talking about implementation science, we're really talking about this. How is it implemented? What are the strategies that are being used? And we focus a lot on the implementation outcomes. Some of these are fidelity, acceptability. You know, Colleen gave that great example of, guess what? The genetic counselors didn't really accept the thing that they were trying or supposed to implement, and that can make a big difference. So those are the outcomes we typically focus on. When we're talking about quality improvement, we are often focusing on these service outcomes or service system outcomes. And those you are probably quite aware of: efficiency, safety, effectiveness, equity, and patient-centeredness, and those types of things like timeliness. So this is different. Both of them are different from your typical research focus. Your typical research focus is on that evidence-based practice and then looking at the patient outcomes. So you can see there. Another big difference is we really want to focus on the actual benefits to the target population. Obviously, the reason why we pay attention to quality improvement and implementation science is ultimately it's to benefit those patients. But in these types of studies, we usually control for the context rather than trying to understand and adapt to the context. But that's what we're doing when we're talking about implementation science and actually quality improvement, is we're trying to understand and adapt to the context, because we need to know what works for who, when, and in what context. So both implementation science and quality improvement consider multi-level contextual factors, several of which are shown here, the different levels. So you can consider a lot of different things that might be influencing what's going on, how it's being implemented. These contextual factors can facilitate or impede the implementation of the thing. The other thing that's interesting that I want you to think about is, when you implement something, we can actually alter those contexts, and they can be altered by the thing. Something to consider. Because if the thing can impact the context, that might be something that you want to measure. We want to make sure it doesn't negatively impact the context. And then that's one of the things that is kind of in common when we're talking about implementation science and quality improvement is we want to see if it's impacting the context. And a lot of times, both of these areas focus on the cost of the thing as well. So again, some overlap in some of the outcomes. There are other similarities, and one of the similarities, it may not be called this in your quality improvement, but you use implementation strategies. So Colleen changed that email. That email is an implementation strategy to try to get uptake of her thing. So that is an implementation strategy. There are a lot of things that we do that you all have done, I'm sure, that are implementation strategies. We often engage stakeholders. We often do some planning. We often educate. We may render assistance. Some of the things that we don't do quite as often, though, and maybe consider less, but could be very helpful, and come from implementation science are restructuring. Sometimes it's easier to restructure to work around a barrier. We can use financial strategies, change the policy, and don't underestimate how much providing feedback can actually help make a difference as well. So those are a lot of the similarities, but also when you're doing them, you do want to conduct ongoing evaluation. You want to see what's going on, how things are changing. And we have a lot of overlap in the evaluation methods that are used for quality improvement and implementation science. So in a nutshell, to conclude, we have the thing, which is the innovation or the evidence-based practice, or if we're talking quality improvement, it's just the process that we change. And then we know that traditional research is really asking, does the thing work? But that is not necessarily the focus of implementation science. You can study that, people often study that alongside some of the implementation outcomes, but that's not typically the focus. Then we have our implementation strategies, which are what we do to help people and places implement or do the thing. And then finally, we have our implementation and service delivery outcomes, which are really how much and how well are the people and places doing the thing. And there you have it, your basic implementation science. So what questions do you all have at this point?
So there are a couple of, is it on now? Okay. There are a couple of questions in the online submission. If anybody wants to come to the microphone to ask a question, you're welcome to work your way there. I guess one question I'd like to ask reflects a lot of my own experience with learning about implementation science, which is we have all this, like you just did a great presentation about the thing and does it work and how does it work and what's the context it work in. But could you just tell us, like, what is implementation science?
Yeah, so implementation science is really the study of how to make the thing work better in the context that you're going to implement it. And so a lot of the studying involves studying how well those implementation strategies work, studying a little bit about how, when you implement it, how the context affects how effective it is or how it impacts the context in return. So that's part of what implementation science does as well.
So implementation science is complex, is what I'm
Yes,
hearing.
implementation science is very complex. I think that's why it's so challenging, because you're having to think on these multiple levels and you're having to think about interactions and how this depends on this, and it all depends on context.
So here's a question that builds on that. Can you give an example of the thing influencing the context?
The thing influencing the context. Yeah, sometimes when people have implemented a thing, it has actually changed the way the providers interact with the patients. So if you think about that, sometimes when you change a process, you actually end up changing some of the behavior of the individuals, whether they don't always even realize it, but sometimes they do realize that they're changing how they respond, because you change one thing and then you have shifts in other things.
Any other questions? I don't see anybody at the mic and I don't see any more here. Okay. Thank you for clarifying so many of the terms that are in our, oh, sorry.
Sorry about that. This is something I've been thinking about for a while, and I was hoping you could help me understand it better. When we talk about evidence-based practice, where do we draw the line? Because, for example, genetic counselors are a great thing, and where is the evidence? I think there's a lot of evidence, but it's not gold standard RCT evidence. So in choosing an implementation intervention, we should evaluate the evidence associated with it, but I'm not clear how or where we draw the line.
Because nobody is. I think that's the honest answer. The honest answer is how much evidence is enough evidence for us to roll things out. And different people have different standards and different levels of evidence. And honestly, part of the reason why we need implementation science is because you can have these wonderful randomized control trials that show that this thing is great, and then you roll it out and it doesn't work. So clearly there are other things going on that are impacting the thing, and so we really need this implementation science. And that's part of the reason why implementation science has done some hybrid studies where they're looking at both some of these implementation outcomes as well as some of those effectiveness outcomes. And I think those hybrid studies, which I didn't want to get into too much of the lingo, it gets kind of complicated, but you can look at some of both. And when you look at some of both, I think that is very, very helpful, because then you're getting some additional evidence that something's working in real practice.
So one of the questions in the chat is how you discussed how in QI there can be rapid cycling of processes. And they were wondering, how can that be studied? And I feel like that really builds on what you were just saying.
Yeah, so in implementation science, they have started getting into some of these ways to study some cycles, but they're typically still not as rapid as you see in quality improvement. But yes, there are some methodologies that can look at some of these cyclical changes that you can make, because we recognize, I mean, implementation science has learned from the quality improvement lane, and I think we're cross-pollinating enough to realize that we need some of both, and we need a way to study some of those cycles.
And then question here at the mic.
Yeah.
So there's a switch that you just flip, Adam. Thank you. And to repeat the question, you were asking about the tension between
doing it right now. You have
doing
a
it
problem
now,
and you need to fix it now, versus actually studying it, gathering the data, and sort of having the evidence moving forward for why you did what you did. And so if you could comment on how you decide when to use an implementation science framework, collect the data, and when you just have to fix it because
you're in cancer clinic and you've got a 6 months wait list and there are people that need to be seen.
Right. 3 counselors have cried in your office that week.
And I think sometimes you do just have to fix it, but I think you can look at the implementation science literature to find out better ways to fix things or try things or use theory to help guide some of the things that you're trying. And so I'm not saying you have to always do an implementation science study, but I do think that some of these principles and some of the theory can help guide some of those decisions for how to fix it right away. But there's no clear answer to that either.
So
can I add to that, Debbie?
Yeah.
I would also add, it can also help you with what are you going to measure and how are you going to report it? So the answer is sort of yes and.
Yeah, you can do some pragmatic measures that don't take a lot of effort. And when you're measuring things from a quality improvement standpoint, that technically is not research. So it's not implementation science research, but doesn't mean you can't be systematic about it. Remember, the word systematic was in the quality improvement definition. So we do want to be systematic in that as well.
So
It is data. It's practice-based evidence.
I can already tell we're going to have a really lively panel this afternoon. So I'm super excited. If you have ideas for the panel and questions that you want to be sure get in that, you can already be submitting them online. I will flag and highlight some of these to save for later if they're more complex. We have about 25 minutes where we can look at activities 1 and 2. So I'm going to point you back to your facilitated discussions on the worksheet. Hopefully this helps to clarify some of those terms in activity 1 and give you a bit more of a framework for how to go about answering those. So we'll see you back in about 25 minutes for our next talk.
I just want to add that hopefully, is this on? Hopefully the distinctions between my project and Cindy's project going forward, because my project, like I said earlier, it needs to happen fast. So hopefully they will address that last questions.
Yeah, so some of us will say there's not a difference between QI and research, that it's all research, and others of us still make a distinction. So you may also hear that tension across the day today of QI and research are kind of the same thing, but also there are some distinctions.
The IRB makes a distinction. Sorry.
Well, sure.
That little thing.
And it's not always logical on the depending. The IRBs of different institutions make different determination.
I said activity 1 and 2. Yes. I see. Yeah, if they get caught on. So maybe give this try to.
Check, check, 1, 2, 1, 2.
All right, I'm going to interrupt your discussions again for a couple of announcements. First of all, I want to put in a quick reminder plug that we don't expect you to get through all of these questions or answer them all in detail or even answer all of them. We hope that you take these worksheets with you and continue to work on them after. Continue to reach out to those of us that are a part of presenting with questions that you have. So, normalizing, you're not going to finish this worksheet. To that end, please move on to activity 2 if you haven't already, and leave the rest of activity 1 undone. And finally, some of you may be wondering about slides being available. We are currently working on getting those in the NSGC app. There was an extra step that wasn't clear that we needed to do. It is now done. It is coming. So refresh the app in real time. It should show up sometime. Colleen says it's here now. So slides should be available, which could be helpful going back to, say, Debbie's slides to work on activity 2. So I will give you guys another 15 minutes to clear through activity 2, and then we'll move on with our example projects. All right, I'm gonna rein in the conversations. I so appreciate how engaged everyone is in discussing these ideas. And I'm so excited for these conversations to continue even after today. But to keep moving us along, next up, we're going to give our example projects and the answers to activity 2 for our 2 examples. So take it away, Cindy.
All right, everybody. So, activity 2, I have to acknowledge that Colleen and I were just saying to each other, boy, these worksheets would have been a lot easier to fill out if we'd had the chance to hear Deb give that talk. So you guys are a step ahead of us. So just to remind everybody what this project is, this is an implementation research study trying to test whether or not a point of care cardiovascular genetic testing for inpatients with pre-test education by video is effective. So the question we were working on our worksheet is, well, how will I know if the thing worked? That's the thing, the point of care genetic testing with pre-test education by video and then referral post-test for genetic counseling. And so in no particular order, I was brainstorming. Well, how will I know if the thing I implemented worked? Well, I'll have an increased proportion of referred patients receiving their clinically indicated genetic test. I'll have an increased total number of patients referred for genetic testing and counseling compared to historical averages in our settings. I'll have an increased number of inpatient consults and genetic counseling appointments. This is a particularly important point in my mind, a decreased time to receiving clinically meaningful results for the patients seen as inpatients compared to patients who were historically referred. And then we were thinking more on a patient level. Acceptable patient knowledge after the video, low decisional conflict, which we were just chatting about this. Debbie introduced us to the SURE scale, or Adam Buchanan as well, who's in the room, and so we really like that, but maybe the decisional conflict scale. Patients will be reasonably satisfied. The referring physicians will be satisfied with the service and actively engaged in it. Genetic counselors will be feeling better about what we're doing. And then just nitty gritty, the video will actually be shown in the test ordered for a high proportion of interested consented patients. So that's brainstorming. That's in no particular order. And I think given we just worked through the worksheet, it says, well, it's advantageous to measure both effectiveness outcomes and implementation service delivery outcomes. So effectiveness is what I do. So it's like, all right, well, what's effectiveness here? And I would actually invite Debbie and Alana to correct me if I've got this wrong. I'm learning along with everybody else here. So we're thinking, well, effectiveness, certainly an acceptable patient knowledge, which we've operationalized as the knowledge scale of the multidimensional model of informed choice. There's developing cardiovascular scales that are going on in our community. Relatively low decisional conflict regarding the genetic testing decision. And then this again, increased proportion of patients referred actually receiving their genetic testing and decreased time for patients to receive clinically meaningful cardiovascular genetic testing results. So we felt good about effectiveness. Although I have to say, these last 2 bullets, a little unclear to me. Is that an effectiveness outcome or a service delivery outcome? Maybe we can talk about that later. I wasn't 100% sure. So then we're on here on the implementation service delivery outcomes. So process and service and care delivery. All right, so the videos are actually shown to a high proportion of the interested referred patients. Most patients complete the video. Genetic testing successfully ordered by the nursing staff and the physicians for a high proportion of patients who consent to testing. The post-test genetic counseling appointment gets scheduled and the patients attend the post-test appointment. That was reasonably straightforward. And then there's this adopters, implementers, health systems outcome. And so for that, I binned the referring physician satisfaction with the service and participation in the service, the genetic counselor satisfaction and acceptance of genetic counseling. That I don't consider to be a problem, given we've built this from the ground up. And then here in red, an increased total number of patients referred to genetic counseling or testing. But again, I'm not quite sure. Is that an implementation versus a service delivery option? So I will leave Colleen to come up, and then hopefully Debbie and Alana or some of our other experts can help me sort out the red box questions.
Okay. So I'll also give a refresher on my project. So this is for pretest oncology genetic counseling referrals that we're going to give them our digital education tool before the GC visit. And then the GCs are going to modify their counseling to involve less education because of the education they received beforehand. So that's our thing. So how will we know if it worked? Shortened visit length. It's one of the things we're after, that the quality of care remains high as indicated by patient satisfaction, which we already routinely collect. All of our patients get a patient satisfaction survey. Also, what I'm broadly calling feedback, I'll show you in that more detail later, but we have a few questions in that satisfaction survey that are things like, there was enough time in the session for my concerns, the genetic counselor supported me and listened to me. Knowledge and decisional conflict. You'll see some similarities there for me and Cindy, given some of the overlap in our things. We'd hope that our GCs would be more satisfied with their sessions. This kind of thing we've been chasing in the profession for a while now, which is instead of saying the same thing over and over again to people, let's give that to them another way. And then you spend more time on tailored psychosocial decision-making type counseling. We also want to make sure that the people actually did the thing, got the thing, so that the genetic counselors, most of them changed their counseling, and that most patients completed the digital tool. So like Cindy, I've done a lot more effectiveness studies. However, in the recent years, a lot of what I've been doing, I now understand to be having implementation and service delivery outcomes without effectiveness outcomes. My brain still hurts a little bit on this. I'm still not totally sure. But when I tried to sort my outcomes into these two buckets, first I was like, what we are really after in our practice is shortened visits. So that's the effectiveness outcome. I'm like, well, no, because effectiveness, if I'm understanding right in the implementation science context, effectiveness is about the impact on the health outcomes for the person receiving the thing, for your patients. But the whole point of our project isn't that, right? It's to change the way we provide service to increase efficiency and potentially increase genetic counselor satisfaction. So, okay, it's not the shortened visit. Maybe I don't have an effectiveness outcome. And this was all, I was very fortunate, kind of like you guys are doing at the tables right now, to have a lot of back and forth with Debbie and Alana, who are the architects of this worksheet, and help me evolve my thinking to say, well, wait, in an implementation science context, your effectiveness outcome can be that there's no negative impact on patient outcomes. So I'm not trying to implement a thing that will be effective at improving patient health outcomes. I'm looking to improve service delivery outcomes. But when I do so, I don't want to make patient outcomes worse. So that was like, wow. So what are my effectiveness outcomes? Well, this is where my thinking is today. I'm looking forward to getting some feedback, through this session as well to see how it might evolve. So no negative impact on patient outcomes. So compared to when we're providing care without the thing, what we're doing now, which is typical pretest genetic counseling 60-minute visits, there'll be no decrease in knowledge. There'll be no increase in decisional conflict. Forgive me, that's not as clear as you measured with the SURE scale. And there'll be no negative changes in the patient feedback we routinely collect, which is satisfaction, enough time in the session, that they perceived they understood what the GC told them, and that they felt listened to and supported. So then what are my implementation and service delivery outcomes? Well, I think almost every abstract we've had accepted here for the last several years was reporting on what I now understand to be implementation and service delivery outcomes. So for this specific project, it's a shortened visit length for the GCs, that they're more satisfied with their sessions, that they perceive their sessions to be less repetitive, that they find this change in their practice acceptable, that patients are starting and completing the digital tool, that they're actually getting invited to use the digital tool like they're supposed to be, the kind of the implementation outcomes around the digital tool. And then for the change in the counseling, right? Because it's a two-part thing, right? The digital tool and the GCs revising their counseling. that they are revising, the genetic counselors are revising their counseling in the way we intend, that the genetic counselors who are leading the effort for the GCs to revise their counseling train them in the way we intended, so they're part of the implementers, and that not only do the GCs revise their counseling generally, but they do it for most of their patients. So that's it from me. I think Erica's up next. I'll hand it over to Miranda.
All right, a number of our talks this afternoon are practical examples of studies that have used some sort of implementation science thinking and applied it to a genetic counseling context. So up first, Erica Bednar is a genetic counselor at the University of Texas MD Anderson Cancer Center. Her work is focused on increasing access to genetic services and cascade genetic testing across diverse clinical environments.
Good afternoon, everybody. Can everybody hear me better now? Okay, I'm short. Hi, everybody. So I'm excited to share with you all some of the work that we've done in part through MD Anderson, but in collaboration with a lot of other genetic counselors across the country. We called this program the BRCA Quality Improvement Dissemination Program. So I have no conflicts of interest to disclose. And like I mentioned in the title of this program, it is a quality improvement based project. And as others have discussed earlier, and I like this diagram that shows that all of the fundamentals of quality improvement theory and methods sort of fit right inside that implementation science bubble. So these are all relatives to one another. They take and borrow methodologically in how we approach these things. The other diagram here, the traditional translation pipeline, I like to use it because it helps describe sort of what we did. So we started locally at MD Anderson doing quality improvement work to help patients access genetic counseling and genetic testing per guideline recommendations. We took that over to LBJ, which is our safety net hospital staffed by MD Anderson, tried it out there. Do the same things work? What did we need to adjust? Overall, we were having success with our quality improvements, so we decided to then disseminate the program outside of MD Anderson so that more patients could potentially benefit. And as you can see throughout these slides, I have a bunch of PubMed ID numbers. I'm condensing a 7-year program into a 7-minute talk. So if you all are curious, please check out those publications to learn in much more detail what all we did. But as a quick overview of how this all started, when we were getting ready to disseminate outside of MD Anderson, if you will, taking it out into the world, the first thing we realized is that most places will not be the same as our place. There will be differences in context, how things work, who people are, all the dynamics. So before we just assumed things were the same and started pushing out interventions, we wanted to understand that environment. So we did what we called an environmental scan to collect data from genetic counseling teams at different hospital sites to better understand their processes, their capacity for doing this type of work, what kind of barriers might be available for us to implement QI interventions. So among those sites who were interested in participating, had the capacity to help us with this program, we designed what we kind of diagrammed it out as like a hub and spoke approach, where at MD Anderson, we were the lead team. We helped facilitate quality improvement efforts. We gave them a database to plug in information. We gave resources and tools and just sort of helped them through all of the complexities, just like what we're doing today, just sort of brainstorming, troubleshooting, working our way through it. We also use this logic model, and maybe I should have put this on the COI slide, but I love logic models and I highly recommend them. It really gets you to sit down and think through, okay, what am I putting in? What are my inputs? What am I actually doing? Defining out all those activities. What are measurable, tangible outcomes, products of those activities? And then how can we link those activities using evidence, theories, frameworks, publications to our short-term outcomes, the cognitive changes like knowledge and awareness? How does that then impact some of the changes we see in the clinic to ultimately impact the care for our patients and the long-term outcomes? The other great thing about logic models is that you can use them for program evaluations. So the first chunk of a logic model we used for our implementation evaluation, really trying to understand what did we do, how did we do it, what were the stuff we were putting in, were we doing it like we planned to do, were things helpful or unhelpful? And we used a lot of our project records, notes, meeting logs, and surveys with our participating sites to better understand these outcomes. We then shifted down the logic model to look at our short and intermediate outcome evaluations. So we did this with surveys of our members at our participating sites to look at some of those cognitive changes that came from our implementation of this program. Like, were they getting more confident in applying quality improvement approaches? Did they feel they had better problem-solving skills? Some of the intermediate outcomes were things like teamwork and system capacity for quality improvement. And we did see some pretty good outcomes when we measured the outcomes of this survey. The thing that varied the most, though, was in systems capacity for quality improvement, in part because some of those measures looked at things like getting acknowledgement or recognition from leadership at the clinic or earning additional funding for future efforts, which we all know can be a challenge even in the best implementation scenarios. So finally, we also did the long-term outcome evaluation looking at impact on patient data. So overall in our project, we did see improved outcomes for our patients with breast and ovarian cancer and getting their referrals, counseling, and testing. We also saw decreases in the time it took for them to receive those services. Now, site by site, these outcomes varied in terms of their statistical significance because every site was a little bit different. And they all also did different interventions, which are mapped here on the impact effort diagram. We used that to help us better understand maybe what worked better or what was more bang for your buck, if you will, that required less effort to implement. So these things hopefully will help others as they embark on this quality improvement pathway. And of course, none of this would have been possible without the team of genetic counselors and other clinicians across all of these different centers. So it took an entire village, as you can see, but I'm super grateful for everyone who was able to put in the time and commit to a multi-year project. It was definitely a great outcome for our patients across the board, and I'm happy to answer any questions as we move on to the session.
All right. Next up, we have Dr. Catherine Wang, is an associate professor in the Community Health Sciences Department at Boston University School of Public Health. Dr. Wang's work focuses on the effective translation of genomic discoveries into clinical and public health practice.
Ooh, how much time do I have? Got it. All right. No conflicts to disclose. So what I'm going to do today is talk a bit about, I was tasked with really thinking about, the typical GC questions that we're all struggling with, and thinking about it from an implementation science standpoint. And so what I thought I would do is sort of piggyback on some work that Colleen is already working on, and thinking about the question that we've been working on for a couple of years, is really thinking about how do we increase uptake? This issue of genetic counseling and testing for hereditary cancer, and I do a lot of work in multimedia, and a lot of interest over the last, I want to say, decade or two, really thinking about how do we automate various processes by which we can use these digital systems to really identify people who are at risk. And so I'm an implementation scientist by way of thinking about it from an intervention standpoint as well. So really thinking about, if we're going to do any solution, any intervention, when we design it, we have to think about two things always. The first is always, are we getting at the right problem? Why are we designing these tools? What are we doing here? So this is our evidence-based practice, but like, what are we trying to fix here? And did we do a good job trying to fix these in terms of really what's causing it, so the determinants? The other aspect of it that we always have to think about here is, did we deploy it well? Did we implement it well? And if it did, and those two things are really well thought through, then we should have success. So piggybacking on Erica's talk, Erica, I love your paper, by the way, in genetics medicine. I cite it all the time, and thinking about sort of like, what are we really trying to target here? We are in a system of care delivery where there are a lot of steps along this continuum. And at any point in this continuum, we may need to design something or have something that will facilitate the patients or participants getting through that next step.
So are we talking about sort of identifying these eligible participants, referral to genetic services, and then how genetic services are being offered, either through delivery of actual genetic counseling or even point of care, how are we coordinating testing, and so forth. And so thinking along this continuum and really thinking about what are we doing and what are the questions we should be asking that we may want to actually study in terms of like the strategies we're deploying and how we're rolling out any new innovation we're considering. Okay, so thinking about how a digital solution, for an example, was implemented, a lot of the IS questions really thinking about why it might fail. And this may help you identify sort of the questions you should be asking and the things you should start measuring. So why does a solution fail? It wasn't acceptable. It wasn't agreeable. It wasn't palatable to patients. It was too complicated and your patients are vulnerable. They don't speak the language, or low literacy. They can't even engage with this digital technology to begin with. It isn't appropriate. The fit is poor. It's not relevant. It's not suitable for the practice setting. It's not feasible. And to the extent to which you can actually use this in the setting that you're considering. The other thing I want to sort of discuss here is really the issue of equity. And thinking about any strategy you develop, any innovation you're trying to roll out, looking for the question of equity and whether or not we see disparities in terms of the delivery and the adoption and the feasibility, really, across different vulnerable patient groups. So let's talk about a possible solution here. Will a digital tool work to identify those at risk? We have a tool. We have a lot of tools. There's a lot of tool developers represented at this conference, many from industry, many homegrown, but we're all trying to do the same thing here in terms of risk assessment and efficiencies. So we have the what. We know what it is. It's some sort of system and tool. What else do we need to think about here? When are we going to deliver this? Where are we going to deliver it? What's the setting? What are we thinking about here? These are all IS-type questions. How are we going to do it? How are you going to roll this out? Who's going to onboard anybody? Is it going to be automated on their own at home, or is it going to be done through a clinic, through a tablet? And who's going to be the target? Okay. For whom is this going to work? So I'm going to give you an example from data that we actually have. This is a classic example of, I have no partnership with this company other than getting access to data that they love giving me, and I love looking at it. So this system is Cancer IQ. Those of you who don't know, there's sort of a system here where there's a navigation component, there's a risk assessment component, they spit out algorithms, they identify who's at risk, and they're plugged into clinical settings. And so we had an opportunity to look at data from 27 clinical sites where the system was deployed. And what was really unique about this, for us to answer some interesting questions, was that they were deployed at these clinical sites across 4 different clinical workflows. And so different clinics chose different ways to roll out the same tool. And some of it depended on their existing workflows and what was feasible at their setting. But we could actually look at the differences in outcomes depending on how the clinical workflow was implemented. So we had a traditional workflow, which is your identification and ascertainment, find these people at risk, refer them to genetic counselors, and then genetic testing. Point of care scheduling was trying to figure out efficiencies in the scheduling process, because if you let people out of the clinic, it's hard to track them down. So if we do point of care, kind of like meds in care, we can schedule you, you're out, you have an appointment, and you're perhaps more likely to come through this workflow. Point of care counseling was really a situation where perhaps the site didn't have counseling in-house, and so partnered with a third-party vendor who could do the counseling at the point of care and perhaps do the testing then on-site as well. Point of care testing, which we've seen a lot of mainstreaming approaches now, is really ascertainment, finding these people at risk and offering them testing at that site at that time while they are there. What you find, or what we found here, was pretty big differences in terms of counseling uptake and testing uptake just by implementation workflow to begin with. And so we saw almost a doubling of just sort of uptake of testing in the point of care testing arm. I shouldn't say arm, observational sort of condition here. And so we thought, okay, well, this is great. And we can think about all the reasons why people can't make it through based on the referral model. And that helps us identify sort of workflow issues that we may want to try and ameliorate. But I think what's really particularly interesting is 2 points here. One is for point of care testing, we're still only at 35%. So is that good enough? And what's explaining variability? And what else do we need to be doing here to improve outcomes? Other questions about like what's going on, why is it working, what else may be, things that we could look at to try and understand nuances. Well, if you look at just testing uptake across the various workflows, you see a lot of variability. Okay, so even in our point of care testing condition, we see a lot of variability. And so what's highlighted in pink and even a dark pink are our screening mammography and colon endoscopy sites. What you see in dark are our sort of primary care oncology, GI sites, and so forth. And so obviously different types of clinics have different approaches in terms of what they adopt, but even with that, we see variability. So it basically emphasizes that we need to understand context. And what are the context questions that we need to understand to explain this variability? Part of it might be density. Part of it might be sort of like insurance at the site. We don't know. And so this is something sort of like, this is the first pass of thinking about, now that we see the variability, what is explaining the variability? So then we can understand the context and the issues of how these things are implemented and where they might work. So last thing here I'm going to talk about is, for whom does the intervention work for? So you see the variability, you see maybe point of care testing is great, but what else is going on here? We had the opportunity to analyze the subset of our clinical sites here based on that had race ethnicity data. And so the subset was 15 clinics. So we pretty much just looked at the referral scheduling combined versus point of care testing. And again, you see this funnel, which is not surprising. And so overall, 22% of the high risk had testing. If they can get to counseling, they usually get testing. That's not the barrier here. But what's interesting here is that, again, we're finding that same finding from before. Point of care testing seems to work much better in terms of getting people through the system and actually getting testing. But if you look closer, this varies as a function of race. And so what we found was that in the point of care testing, we didn't see racial differences at least in terms of black-white comparisons. But in the referral condition, we did. And so what we did is thinking about where the problems may lie. We looked at this by the point in care delivery where we may be seeing differences. And what we found here by looking at this is that the testing differences are most likely explained by the counseling access differences. And so we're seeing differences in access to genetic counseling and engagement with genetic counseling, but we didn't see differences in scheduling. So there's been a lot of evidence saying that there's biases and people aren't getting referred. We didn't see that in this data set. And really is thinking about other barriers that may be at place that we need to think about from an implementation standpoint to circumvent some of these barriers to get people in the system. And this is what we're thinking now in terms of like, what are the strategies we need to deploy? We have the tool, we can find them, but what are the things we need to consider to really get them through the system and accessing something downstream based on other strategies we could be deploying. So summary here, there's a lot to be learned from everyday genetic counseling questions. The more you dig, the more you end up uncovering more questions that you have to ask. And we have to think beyond the initial question of like, does it work? Because we know it works to find people, but we can't get them through. And so like, when does it work? How does it work? For whom does it work? And why did it fail? And so again, measurement is key here, thinking about it right from the get-go. Otherwise, you think in hindsight, oh, I should have measured that. Would have been great to know. So acceptability, these are all metrics people already talked about. Fidelity, dose, completeness, all that fun stuff. So thank you.
All right, I'm going to point you all back to your worksheets for the next activity. We're on to activity number 3. I skipped it. Great. Executive decision to keep us getting to the break on time. If you have questions, I'm sure Dr. Wang or Erica would be happy to answer your questions when we get to the break, but I want to keep us getting to the break on time, so I skipped a Q&A. I was trying to do it very surreptitiously, but now everyone knows that I made an executive decision to skip the Q&A. All right, so activity number 3, and enjoy. We'll come back in, so I don't say the wrong thing. We'll come back in 20 minutes with Cindy and Colleen giving their example projects for activity 3. weren't any in here, and so I just didn't.
Back on. Okay.
Ah. I know, like, here's the next.
All right, I'm going to jump in here real quick with an observation that we just had off of these the wonderful talks by Catherine and Erica. But Erica made something that I really want to reiterate for all of you because I don't think we're talking much today about data sources in any of our talks. Erica noted a whole bunch of different data sources that they used. These were existing sources, logs, meeting minutes, things like that. So your data sources, we tend to think traditional research, oh my gosh, you have to figure out all of your data sources. You have to figure out everything you're collecting ahead of time. And then you get to the end and go, darn it, I didn't collect that. And even in Catherine's study, this was, after people had already implemented and they had these 27 sites, she was using all the data that they had and trying to coordinate that together to create to ask the questions, what can we understand out of what data is existing? What else might there be that we can collect? Same thing with Erica's project, is using all of those things to make it easier for in the clinical environment to collect the data that you have access to. That is okay. And ask the questions and understand what data sources might exist that you can use to answer these questions. And we wanted to make sure that that point got really hammered home for you guys, because I don't think we're going to get a chance to talk about that or really connect that dot for you in any of the other talks today. All right, back to your activity.
All right, we're wrapping up activity 3, and we're gonna circle back to our last 2 presentations before we take our break. So next up are our example research projects as completed for activity 3.
All right, well, thank you all. And I think Dr. Wang set us up really nicely with this next part of the worksheet project. So, why do we anticipate what might influence why your thing worked or didn't work? Again, the thing is pre-test video education for cardiology inpatients, followed by a post-test counseling model for people with positive test results. So, what factors might contribute, in my case, to this thing not working? Well, the thing we're practically worried about is physicians might not make inpatient genetics referrals based on our past inability to efficiently fulfill their requests. We have some discouraged referrers. It's certainly entirely possible patients won't view the video. Maybe they're not given the iPad. Maybe they choose not to watch. Maybe these are inpatients. Maybe they're just feeling too sick. It's possible, even though we know our education video is performing well outpatient, it was performing well in formative evaluation in patient support groups and in the Baltimore, our patient community, but maybe it's not going to work with inpatients. It's possible we'll have just low uptake of genetic testing by the patients, and that we think it's actually relatively likely we're going to have an issue with patients not attending post-test counseling, in which case the clinically indicated genetic testing will increase, but not the genetic counseling. All right, so the next step we were asked to do is to say, okay, well, how will I know why the thing worked or didn't work? Like, that's great, that's a laundry list of things that could go wrong, but how am I going to sort it out? This case, my research brain works really well for this, and I'm saying, well, at the end of the day, this is designed as a research study, so it's nicely going to be structured to allow me to identify drop-off points in implementation as I go through an audit process at each step. Presumably I'll do this iteratively. So we've got a big funnel. The number of patients referred, of the patients referred, who was eligible for testing, of the eligible patients who was invited to participate and consented. That's in red because it's unclear to me if we're going to have to do consent for this or not. Of those patients who was offered the video, of those who offered the video who finished watching it, of those who watched it who said yes to testing, of those who tested, which tests were actually ordered. And then for each of these steps, along the lines of what Dr. Wang said, we have the capacity and intention to do stratified analyses by demographic or clinical characteristics. So in summary, we can figure out where we're losing people in the funnel. We can do stratified analysis to figure out who we're losing in the funnel. And then I think there's an opportunity for targeted analysis that's more qualitative to figure out why we're losing people at this stage of the funnel. So for instance, I imagine us doing interviews with clinical stakeholders to understand reasons for drop-off at each state and why a strategy is not working. So maybe we'll get feedback from the physicians regarding their interest in referring and the efficacy of our referral process, feedback from the nurses regarding the test ordering process, feedback from our genetic counselors, feedback from our research study staff. And then, as I said, and this is weird to me, so I'm a randomized clinical trial researcher. The idea that I'm actually going to look at the patient-reported outcome measure results during the life of the study, that is really weird for me. You would never do that in a clinical trial. But I understand, I think, that I can actually take a look at the pretest knowledge, the SURE scale as we're doing this, and make sure we're not losing people who are just completely not understanding. And finally, so what implementation strategies, so that was the table that was up there earlier, can use to help increase my chance the thing will work? This first part is in red because, again, I'm not sure if I'm using research language, but gosh, before I implement this whole thing, I think we need to test our videos in the inpatients. So I would call that robust formative evaluation. We need to strengthen some of our stakeholder relationships, provide provider education regarding the change in the process, particularly to our discouraged referring physicians, and to facilitate peer support by champions. In particular, that's the case for the nurse. We lost our recent champion. We've got to identify a new champion on the floor. There's this opportunity for audit and feedback, which I think I described earlier, to monitor, to ensure fidelity to the thing. Support for clinicians. We need to make this process easy. We need to have standardized test orders. We need to support our schedulers and our nursing staff to make this possible. And then again, this last one's a little challenging for me. Purposefully re-examine the implementation. So deliberately solicit regular feedback from all of these stakeholders, particularly the genetic counselors, nurses, and physicians, to understand what's working and what's not. And fortunately, that's exactly the end.
I think I'm going to struggle to keep this one on time. So Miranda, get your giant hook and pull me off the stage. Okay. So for my project, the digital education tool before pre-test oncology visits and then revised counseling because they received education. Some of the things I've been thinking about that might contribute to it not working. That the tool itself doesn't do what we want it to. It doesn't make patients sufficiently informed, for example. Or it informs patients well, but they still need the same or more time spent with the genetic counselor on education, perhaps different types of education activities like follow-up questions to what they saw in the tool, or the GC assessing whether they are sufficiently informed. So it doesn't reduce the time in the visit. The GCs don't revise their counseling as intended. We talked about that a little with our pilot. Perhaps that's because they're hesitant to not provide education directly. You know, this is the way they've practiced their whole career. Or they're concerned that the tool doesn't educate people well enough. And we did get hints of some of this in our pilot. Or, of course, what if the patients just don't use the tool, right? Well, that's going to contribute to the thing not working. So how will we know why the thing worked or didn't work? Well, how will we know whether or not the GCs revised their counseling? We actually record our sessions just routinely. It happens automatically in our purpose-built GC EMR, so we can listen back to those sessions. And that could be getting at this concept of audit and feedback in terms of implementation strategies, which I'll get to in a moment. That was a new one to me. It makes a lot of sense, but I hadn't really heard it framed that way. The GCs can tell us whether they're revising their counseling. I love this idea of data sources. Suddenly I'm like, oh, I'm gonna need to just record all these team meetings. Great, I'll record them. We can go back and listen to the recordings. Super easy, we're a remote company, all our meetings are on Zoom. Why didn't they revise their counseling? I may get that from some of the recordings of the meetings. We can also interview the GCs directly. They'll have one-on-one meetings with their supervisor where this could be discussed, and I could get data from those meetings. And again, we might actually get some insight into the why they didn't revise their counseling from listening to the recordings. So there's the, did they revise their counseling or not from listening to the session recordings? And then there's the, is there any signal for why that I might be able to observe from listening to the recordings of the sessions? If it doesn't make patients sufficiently informed, well, we're measuring knowledge and with the SURE scale, decisional conflict. So I might see a signal there. But why didn't the tool make patients sufficiently informed? And we could get some feedback from the GCs on that. What are they observing? You know, maybe that they listened to they used the tool too far before their appointment and they forgot things. Or the tool literacy burden was too high and a significant number of patients, you know, couldn't actually digest the information, just as examples. I'll be honest, in this setting, we're probably less likely to have the opportunity to interview patients directly, but it certainly could be one of the ways that we assess why the tool didn't inform people sufficiently. And again, I might get some insights into listening to those recordings. A little bit more on this, on how we'll know why the thing worked or didn't work. So we'll have these metrics on education. We can look at whether the education in the session took the same amount of time or not, starting just with a variable that we automatically collect through routine care, which is how long was the appointment. And then we also have looked at developing, what wouldn't quite call it qualitative because it's really more counting, but some methods around how much time was actually spent on education in the session. So that's something we may be able to do, again, leveraging the recording. So that's the, did this happen? Did education still take the same or more time? And then why did education take the same or more time? And we may get insights from the recordings. I keep saying that over and over again. Interviewing the genetic counselors could help, also the patients. If the patients don't use the tool, well, first we can figure out whether that happened by looking at the rate of starting the tool and completing the tool. That's also automatically routinely collected just through course of care. And then digging into why. Well, were they actually successfully sent the invitation? Did they actually receive the invitation even though we sent it, which can be two different things. We can interview patients who didn't start the tool or didn't complete it to find out why. And we can also look at some patient demographic or clinical characteristics of correlates of not starting or completing the tool. So this is just to refresh you of what was up on the screen earlier. You have in your resource handout some implementation strategies. This was a new way of thinking for me, and I'm looking forward to kind of thinking about how to pull from this toolbox for my work going forward. So I tried to organize these by the way they're categorized here. So implementation strategies we could use related to the genetic counselors. Again, that audit and feedback. Audit how it's being implemented, how it's being done, provide feedback to the genetic counselors. We could also support the clinicians, the GCs better, provide them mentoring and encouragement that could be from their supervisor. We also have identified a few champions who just ran with it in the pilot. So we can leverage them to provide encouragement, solutions, mentoring. Also just reminding them, like very high volume practice. We're not sure yet what percentage of their patients per week this is going to be. So how can we support them to remember to counsel this subset of patients in this different way? And then we've also been thinking about how sharing the early data on the impact of the tool on patient knowledge and decision-making might actually increase the genetic counselor's comfort and confidence in changing their counseling. So we're actually collecting some of that data now, even though we haven't fully implemented the thing, so that before they implement their counseling, we can show that to them. And hey, maybe that data is bad, and then we need to make some changes before we fully implement the thing. You guys will have these slides. I'm going to skip over the last one a bit. What about implementation strategies for the tool? So first of all, just in that act of purposely re-examining the implementation, just checking to see if they're actually using the tool. I already showed you the example for our pilot where we were able to double our uptake rate just by iterating the contents of the text message. And we also might try different ways of inviting patients to use the tool. Right now, it's all text message based. We might also do emails. These are all remote patients, but we have had settings where the patients are being introduced to the tool in their doctor's office and with a QR code. What about having the staff, the scheduling staff, their trusted doctor's clinic, prime them, recommend them to do this, things like this that we could re-examine how the implementation of the tool is working and iterate on it. Yeah, so I feel like this is an area in particular where I still have a lot to learn. I'm reflecting back on things that I've been doing since I joined Genome Medical that I never thought of as research, and I wasn't really thinking of quality as quality improvement, but were this. Working with clinical and product to optimize the language of that text message, that was implementation. There's a lot of other things like that. So a part of what's happening in my brain is like rethinking things I've been doing through this lens and with this language and framework, and the implementation strategies is very much a big one of those for me. So thank you for those extra couple minutes.
All right. So next up is our break. So we're asking you to be back by 2:55. I'm going to add on 5 minutes to what's on the screen here. And this afternoon, we'll have some discussions of an implementation science framework called REAIM and how we can leverage those ideas to think about a DEJI issues as well. So we'll see you in half an hour, 25 minutes.
selecting dogs like this.
Sit up here for a sec.
That slide was supposed to be up during the break, but now it's up for when people are coming back. Maybe they'll notice. I was gonna say that one.
That one's live.
Yeah. So don't talk about anybody because people are definitely. There are a lot of people from RQO, which is really fun. Yeah. I think it's really good.
Good diversity of experience too. And clinical areas, types of projects, that sort of thing.
I almost forgot to give the rundown. Participants are in.
There's a snack. Should have gone last night. I had these ones. I like a nice real food smooth.
And I've got one of those like protein bars. I don't even know what their name is, but it's like 6 almonds, 3 dates, 2 eggs, nothing else.
RX bars.
What's that?
RX bars?
That's
These things are shoot.
I bought 2 yesterday at the airport, and I had the first one. I was like, I don't like this. So if you got the second one, I'd be happy to give up my.
I find them to be a chore.
Yes.
Like, and impossible to clear out of your teeth without being impolite. End up digging back in there with your finger.
Would you like to have one now?
Well, you sold them, and I have expressed my love of them.
You're sitting on stage in front of people about
Uh-huh.
to talk.
Do lots of mouth noises. Nobody wants that.
Nobody
on the
likes.
feel like dinner at our house. Mouth noises.
Right. Well, ready?
Yeah.
All right. We are next. How many years of research experience? That's what I'm about to say.
It's close.
Nearly 20. You can go from like over a decade to nearly 20. They both sound like a long time.
It'll be 20 in the spring.
Counts. All right, everyone. If you can find your way back to your tables, we are going to get started for our second set of talks for the day. I don't know how you divide sets. Maybe it's our third set, fourth. I don't know. Our post-break set of talks for the day. All right, Adam Buchanan is up next and is going to talk about the RE-AIM framework. Adam is the chair of the Geisinger Department of Genomic Health and has nearly 20 years of research experience, 20 next spring, I'm told, in assessing genetic counseling outcomes and cancer risk management behaviors. He completed training in implementation science methodology at the National Cancer Institute.
Thanks, Miranda. And I would just say it's been great to hear the conversations going on at our table and to see the excitement in the room. I hope this continues. And I think this particular talk is something that you all are already thinking of, these constructs, and trying to figure out how to organize implementation outcomes and others. So I hope this will give a little bit of language to put to what you're already describing in the conversations I've heard. There's my conflict to note in Mitri and you. So I want to start with a little bit of a flashback here. So several years ago, I was driving out to rural North Carolina oncology clinics to provide cancer genetic counseling. And that was a lot of time on local interstates, and sometimes patients wouldn't show up. Sometimes I would have a single patient scheduled and that person wouldn't show up. So one day I was driving back and I thought, there might be a better way to do this. What about this thing called telemedicine? Maybe we try that. So we did and got some funding to try it. And so as we were starting to implement it, I thought, well, maybe we should also study how well this works. So in other words, I thought, can we build a research study around this question of whether telegenetic counseling works as well as in-person genetic counseling? And everybody in the room is probably saying, yeah, that's old service delivery stuff. This is boring and lame. But at the time, it was something that was interesting to us because there was concern that perhaps there's some key differences between in-person counseling and telegenetics. And so we did a study, we published the findings, we found no difference in satisfaction by the in-person group versus the telegenetics group. We had randomized patients as they referred to one group or the other. And then we looked at cost as well. So the story could have stopped there, except that we did what we often do when we do research, which is to kick ourselves when it's over. because there was so much more we could have looked at and that I didn't know to look at the time. And I think you all probably already have an idea of what other sorts of outcomes we could have looked at beyond satisfaction, beyond cost. I'll give a moment if anybody wants to yell out any of those other outcomes we might have looked at in the delivery of the telegenetics and the in-person arm. What are some things that you all have already thought of that you've been talking about in terms of implementation outcomes, different measures of effectiveness? Any quick examples? Yep, access. We'll take another. All right, so there were all sorts of things that we considered. And one of the things that's been helpful in trying to do this Monday morning quarterbacking is to try to organize those questions under a particular implementation science framework. So, am I clicking too far? So, we've been talking about what are some outcomes, implementation outcomes, effectiveness outcomes, but we haven't really talked yet about how might we organize those. And fortunately in implementation science, there are lots of frameworks, lots of them. Many people have their favorite one or two frameworks for a variety of reasons, and some of them apply well to certain contexts better than others. But really, the why here, the why we use these frameworks, is because they help organize some of the complexity. Makes some sense of that real-world complexity, and it allows you to integrate some key features for successful program design, to better understand some predictors of implementation success. So we've been talking about what are some strategies you might use and why might you use them, some factors associated with diffusion of a particular innovation, maintaining that innovation over time, and some appropriate outcome measures too. So in other words, it gives you a way, some structure to think about what you might be gathering data on. And in the ideal world, it gives you a way to do that at the beginning of your process. So implementation science frameworks really are useful for organizing your thinking about how you want to both implement and evaluate a particular intervention. So the one that I was tapped to talk about is one that we often use in genetics and often in lots and lots of other places, the REAIM framework. And my task is just to explain this, to briefly walk you through the domains of this particular framework, and then we'll have some more hands-on consideration of those domains. So this has been in print for about 25 years, intended to describe and help us understand how a program works in the real world, bring some of that order to some of the complexity, and ultimately think about the way those domains interact to consider the overall impact of a particular program or innovation. This, as I said, has been commonly used, cited nearly 6,000 times at this point. So this is one of the most used, most cited implementation science frameworks out there. So just to walk you through, REAIM, helpfully, that's an acronym. Each one of those letters stands for something that we're trying to measure. So the R is reach. And this is typically thought of as an individual level domain. So it is a lot of what we've already been talking about. What is the reach of our program among those it's intended to reach? So that can include some different elements of that reach, things like representativeness of that population. If you know your denominator among the group that you're trying to reach, as Cindy was talking about earlier, then you can do some drilling down of that funnel and take a look at that. Also, it allows you to evaluate reasons that individuals didn't participate. So who did you miss and why did you miss them in your particular program? So just using the telegenetics program we did as an example here of how you might operationalize, we might say, well, how representative were the patients who had a telegenetics visit of the overall patients who quote unquote, should have had cancer genetic counseling in those particular clinics? That's reach. Effectiveness is the next one. That's the E. And so these are often thought of as those health outcomes. They can be things like whether a particular change in whatever health outcome occurred. They can be quality of life. A broader conception is useful here, including unintended consequences, including economic outcomes that can fit under this particular domain. And then it helps to think not in the binary, did a thing work or not? Was it effective or not? but about the heterogeneity. So for whom was it effective, and what are some of those reasons for success or failure? So an example, again, drawing from that telegenetics program, did adherence to cancer risk management differ in telegenetics versus usual care? So that's an effectiveness outcome that we could have looked at, but didn't. Adoption is more about not the individuals, but the settings. So adoption is the degree to which that particular program or innovation is adopted in wherever you're trying to implement it. So that might be how many of the settings that you implemented it in, that you intended to, or what proportion, how representative those settings are that implemented it of the overall system that you're trying to implement in, and then reasons. Again, you can see a common theme here, not just whether a particular thing was measured in such a way, but to the degree that you can, figuring out why. So the example from this particular project, what were the characteristics of clinics that participated versus ones that didn't? And what were the characteristics of clinic staff responsible for implementing the telegenetics? So as an example, there were some clinics that wanted us to set this telegenetics program up in the clinic, and there was another clinic that didn't. They said, we've got a nurse practitioner who does this counseling. We can handle this ourselves. We don't need any additional support here. So that was an element of adoption kind of across those particular clinics. All right, I feel like I'm just kind of being overly didactic. Any questions so far? All right. There'll be time for that. So then next to last is implementation. This is kind of the how. How did you do the particular program? So this includes things that we've already been talking about. What was the protocol for that particular program, and what was the fidelity to that protocol? Did you have to adapt anything, either because your system differs from the place that that particular program was originally tested? Were there cost implications? Cost to implement is often fits under this particular domain. That's a setting level set of outcomes there. At the individual level. For example, what about clients' use of particular strategies, intervention and implementation strategies? So examples of those, we had a set protocol for how to bring patients into a room and sign them onto a computer and make sure that they were able to see a variety of materials on screen there. So was that protocol adhered to? Was it implemented the way it was intended to be? With those visual materials, those could have been things like we're drawing pedigrees in real time and showing those on the screen, or we had diagrams of inheritance and so forth. To what degree did clients interact with those? So those are implementation questions. And finally, maintenance. So there have been lots and lots of genomics programs, interventions that fizzle. And they are successful for a particular period of time because they've got the right conditions in place for success, but they have a transient impact because they aren't maintained over time. They're not sustainable. So this is a key longer-term outcome, one that you usually can only assess after a particular program has been implemented and you have a chance to follow up on it. And it's also one that's both an individual level and a setting level or a system level sort of outcome. So for individuals, if there's a particular behavior that you're trying to encourage, that may be whether that behavior has been sustained over at least 6 months after implementing that particular innovation. For the setting, it's whether that particular setting is still doing the particular innovation. And includes some of the same questions. What proportion of settings are still doing it? How representative are those settings of the overall system that they fit within? What are the reasons that ones that discontinued did so? What adaptations have occurred over time? So evaluating those sorts of outcomes all fit under maintenance. So just a final example from the program that we had was which clinics are still using telegenetics and why might that be? What are their features? I know that several years later, several of them are still using the telegenetics software protocol and so forth. I don't have a good sense of how that's been adapted or what's changed post-COVID or anything like that, but certainly some level of maintenance there, but not something that we ever looked at systematically. So that's the REAIM framework, one of many implementation science frameworks that's useful for organizing the approach, what you're going to implement and how you're going to evaluate it.
All right, so I promise I won't skip the next Q&A, which is scheduled to be after we have 2 talks that highlight examples of using the REAIM framework in practice, and then we'll have a Q&A. So if you have questions about REAIM, now you can drop them in. Otherwise, in about 10 minutes, we'll have an opportunity after Wendy and Barry talk. So up next is Wendy. Wendy Coleman is a genetic counselor and director of the Genetic Counseling Shared Resources at the University of Utah Huntsman Cancer Institute. Her research focuses word missing, brain slow. Okay. Her research focuses on increasing access to genetic counseling, testing, and management for patients with a cancer predisposition. So turn it over to you to talk about your study.
Right. Well, I'm going to try to go really quickly here. I've got no conflicts. Our project, the Bridge study, was sort of the inception of that was trying to address 2 issues. Well, overall, the global issue of how can we address underutilization of genetic testing among primary care. And we tried to come up with a plan to approach that in 2 different ways. One, how could we identify primary care patients who meet criteria for genetic testing in some way that in no way burdens our primary care colleagues or disrupts their workflow? And then if we're going to go about identifying a large group of patients who suddenly need genetic counseling and testing, how can we efficiently and effectively deliver that to them? Because I did not want to get this list of patients and have no plan for them. So this was the issue that we were trying to address and led us to do the Bridge study, which was a randomized control study in which we developed an algorithm that used structured family history data within the electronic health record to identify people meeting NCCN criteria. Those patients were outreached to via MyChart and randomized to either getting a referral to like a standard of care genetic counseling appointment, which was provided by telephone, or an automated self-directed process with a chatbot. And just sort of in comparison to some other projects discussed today, this was a full replacement of genetic counseling. People in the chatbot arm got pre-test and return of results via chatbot. So, and this was done at Utah and NYU. And so we decided to base our grant and this study on the REAIM project as a group of people who were brand new to implementation science. The REAIM framework was very understandable to us. And it was provided a really good structure for us thinking about writing this grant and designing this project. And I'm going to just very quickly talk about 3 of the constructs in REAIM and how we address them: reach, efficacy, and implementation. So for reach, as Adam just described, that's how effectively is this process for identifying the intended patients or recipients, whoever it is in your case. And so we sort of had, so we looked at this of, how accurate was our algorithm in terms of identifying people who met criteria for hereditary cancer genetic testing. And then also, was this identifying everybody equally? Did all patients have an equal chance of being identified? So we looked at this in a couple of different ways, and I'll talk a little bit more about the accuracy of the algorithm. Anyway, it was quite accurate, but we did find that there was sort of lots of issues in terms of things being missed by the algorithm, and one of our next steps is going to be kind of fine-tuning that. I'll talk a little bit more about that. But we also, like I said, looked at how effective the algorithm was at identifying all patients equally. And it was not. So an algorithm, whenever you're using data using data from the electronic health record, you're dealing with the fact that there are underlying disparities just in the delivery of healthcare and the availability of data across different populations. So if you are non-white, male, Hispanic, or do not have English as your preferred language, your chance of having enough family history documented in the electronic health record at either the University of Utah or NYU was pretty low. The people we are identifying by the algorithm did not match the demographics of our population. Now, this did not mean that we're not gonna, once again, that the algorithm maybe isn't necessarily effective. We identified almost 30,000 people who did meet criteria via this approach, but it's really important to know who we were missing and that we need another strategy to identify those individuals. So for efficacy, that was our desired outcomes. And our outcome was uptake of genetic testing. And I know this has come up kind of in some of the other talks today about when we're thinking about genetic counseling and testing, is that the preferred outcome? We approached it as that people who meet criteria for genetic testing for hereditary cancer generally are going to benefit from that. And our primary outcome was the uptake of testing, and then also uptake of the recommended cancer screening. We do include some surveys about satisfaction and some things like that, but overall we were anticipating that those were going to be quite similar across both arms, and we were looking at the more concrete outcomes of the testing for our outcomes and what we presented in the grant as our goals. And we've looked at this by counting. These were outcomes that were easily obtained from the electronic health record. We don't have to survey patients to find this out. We're not losing data based on completion of surveys. All of this is able to be tracked. We've tracked the patients all through the process from those identified by the algorithm. We found that both NYU and Utah, about 30% of patients flagged by the algorithm are ineligible. We also then looked at how many people looked at their MyChart message. Once again, the importance of thinking about an implementation science looking broadly, because the exact same MyChart message, 76% of people in Utah open it and 28% at NYU. So we did find some differences, but then looking at, like I said, each step in the process, how many people either followed up on their genetic counseling referral versus completing the chat, and ultimately completing testing. And then that final piece, that implementation piece, and I really think about this as, what is the roadmap? What can I give, or could we give from this study to hand to another center that wanted to implement something like this? What are the steps in the process? And so, the implementation outcomes that we were looking at were the patient responses to the patient portal message, and the completion of the workflow by the genetic counselors and genetic counseling assistants that were, helping the patients in these two arms of the study through the process. And we did this by trying to build into our study design a lot of tracking of outcomes. This is something that I really learned a lot about, because, whereas other studies that we have done in the past, which were very controlled and done in a specific kind of isolated study environment, implementation science you do in the real world. And that may mean that your data collectors, your study coordinators, are actually MAs and genetic counseling assistants and people who are trying to do another whole job. And then you're trying to add on some of these different outcomes and things. So we did things all from establishing tracking spreadsheets for them to follow to actually just having someone sit and watch them, so that they didn't have to be writing down everything that they were doing, and we could sort of collect data on what their process was to translate that. And that's been important things. The things that we're finding that we need to tweak and probably change to increase those uptakes and things are really based more on the process rather than any component of the messaging in the chat or the counseling itself. So those are my last points. So I'm not too far over. Hopefully. So thanks.
All right, our next talk is Barry Tong, who is a cancer genetic counselor that practices at UC San Francisco and Zuckerberg San Francisco General Hospital, and currently serves as Secretary Treasurer of the NSGC Board of Directors. His interests include service delivery, healthcare disparities, and genetic counselor training and development.
Thank you. These are my, excuse me. These are my disclosures. I just want to say I'm coming from the perspective where I'm coming from a clinical setting, quality improvement. I'm the first in my family really to be in healthcare and in research. And so access to services is a very big focus, and you'll see that as a theme in what I'm talking about today. And I'm really coming at the perspective of like, we don't really know what we're doing. Re-AIM came into it as our fellow was writing up our experiences with genetic testing station, which is really our, I won't go into a lot of detail, it's in a lot of other places, but our service delivery model, because we needed to get a lot of genetic testing done in the cancer center. And like the examples provided before by Debbie, we just did it. There was no evidence base. It was done quickly. We've changed constantly and rapidly. Everything you see in red are things that change like probably on a weekly basis. And so there's like constant flux of what that process and implementation actually is. There's elements regarding like who's actually delivering it. Pandemic happened, it went remote. We changed our sample types. We moved to a red cap consenting module instead of a GCA phone call. That kind of failed some of the time, so we got processes in place to make some work and some not work. And then there were genetic counselor tasks on the back end that we varied over time as well. And so like we initially had post-test counseling for all, that didn't work for every patient. We had some letter and some with the genetic counseling visit, and then we've mostly moved towards just a letter with opt-in genetic counseling. And we did not look at any of these changes in any sort of a research framework whatsoever. We just did it. And so when we applied an implementation framework, which we had been thinking about, and we like attempted to apply for some grants, but we never actually got around to finishing the grant or submitting any of them. So we had some sense of like, oh, we can use Re-AIM, and we've kind of operationalized some of these terms. But what really helped was we had, as oftentimes happens, is we had a geomedical oncology fellow who was becoming a junior faculty and was interested in the data set that we had, because we had actually like somewhat inadvertently collected all this data just in the process of our kind of clinical pass off from GCA, from the referral information back to our genetic counselors. And so we had this data set that was built on like a very archaic database that's been at UCSF for decades. And we just kind of like mashed things onto the Re-AIM framework. And after today's sessions, I realized some of these are very underdeveloped and probably wrong, but it's published, so it's there forever. In terms of reach, we really looked at things like number and eligible individuals referred to our genetic testing station, effectiveness, much like has been talked about today. We looked at achieving germline testing within a certain time frame because of our cancer patient population as our effectiveness. Adoption, we primarily focused on number of settings and providers involved in the genetic testing station process. And then implementation and maintenance, I'll be totally honest, we just kind of put some words in there so that we could say we use the whole thing. From a reach standpoint, this is where we had some of the most robust data, because we had a denominator of the patients we should have seen, how many patients were referred to us, how many of them successfully progressed through the genetic testing station, how many we completed testing, how many completed testing through our known diversions where we would pre-identify that they needed pre-test counseling. And we documented, as far as we could tell, the reasons for non-completion based off of our GCA notes or things we could find in the chart. Out of here, we also looked at some of the disparities in reach. So we found, as has been echoed in Wendy's studies and others, Black race, Hispanic ethnicity, and limited English proficiency led to lower odds of testing completion. And again, in this learning process, we then tracked what steps in the process we had these failures of completion, and that's one of my posters, a little kind of plug about which steps in the implementation which led to these reduced reach. And then from an effectiveness standpoint, we wanted to look at the proportion of patients who completed that germline testing within this time frame that we just kind of made up. And the denominator varied depending on our setting. In the prostate setting, we had the number of referred patients, but in other settings, we had a total number of like pancreas patients, for example, and then a turnaround time from referral to patient disclosure, because that was the true receipt of the results. From adoption standpoint, we looked at the number of providers in the geomedical oncology clinic that actually used our genetic testing services. We could actually look at, did they just place a referral to genetics, or did they actually put in our order set, and what fidelity they had to the actual processes. We looked at different trends in its use, while not in this paper. We looked at like whether it was the med-onc ordering or the surgical oncologist or the radiation oncologist. And then we also, through kind of our meetings and our weekly meetings about genetic testing station, the participation of the cancer genetic counselors in the process of processing results and understanding the workflows. And just my acknowledgements for all the many people involved in this process. Thank you.
All right, so Adam, I may ask you to make your way to a microphone in case there are questions that get submitted for you. I'm going to start with a question for Barry. With your project protocol kind of changing rapidly, how do you approach the IRB process? Is it a retrospective review, or what did you do there?
What IRB? First of all. Second, again, we had this, definitely QI, but all of our patients we did enroll in like our research registry, which is this like grandfathered in, very old, like broad. The IRB language doesn't even apply to what we study anymore, but we can continue this like patient registry for continued contact. And so we did not submit an IRB.
This question wasn't for me, but our IRB, we approached even both arms of our study as clinical care. We were not developing new guidelines, like these were established NCCN criteria for genetic testing of people based on family history. It was a standard hereditary cancer panel test. And the content of the chatbot was developed based on our counseling sessions. And so we basically said to our IRB that we are, we have to expand our services. We're delivering our services either of these ways, and we are going to be assessing that. And so most of it was done under a waiver of consent to just pull the outcomes from the EHR. Patients do get a survey, which they consent to by completing the survey, but that's it. No one is getting consented to be randomized or picked up by the algorithm.
There's one more question online that I'm going to throw to Adam, and Alana has a microphone if you have a question, want to raise your hand and don't want to make your way to the front. So Adam, the question I'm going to pitch to you is, can we analyze a process using implementation science if we've already done the implementation? The specific example says from pre-test to post-test GC, but broadly, can you use implementation science if you've already implemented something?
Yes.
That's what I was hoping for. Would you like to elaborate?
So, of course, it's ideal if you have the forethought to plan it ahead of time with the outcomes that you're going to assess and collect the things that you think are going to be relevant for your particular project. But you can also do some retrofitting, and you can still learn quite a bit from what's already occurred. And, just Barry, like you described, you realize that re-aim fit what you were wanting to know about how the program had worked. So you can do some of that retrospective approach, and it can still work and still do the overarching goal, which is to organize your thinking and organize the outcomes that you're interested in and give you a sense of not just whether something worked, but why. So you can do it post hoc, and it's still a useful way to organize your thinking.
No other questions online, and I don't see any raised hands. So we will move on to
So I do want to address.
Alana raised a hand.
I actually do. I want to address one thing. So Barry, I noticed that you said that you guys just kind of threw in implementation and maintenance so that you would have something to show. But I think you really did have the ability to, as you showed, you were able to find those in your data and measure those. But I do want to address something. So so as a so I trained under Russ Glasgow, who will admit that REAIM is his one-hit wonder. So question always is, do you have to use all 5 constructs in the framework? Do you have to measure all 5 all the time? The answer is no. No. If it doesn't fit, it's okay. Sometimes you can't do adoption is a big one. You can't do adoption because you have a self-selection of clinicians or of settings that are doing it, or 3 settings were told, you will do this pilot. There is no adoption. The 3 settings had to do it. You can measure fidelity and all that other stuff in implementation, but you can't measure adoption. So sometimes not all 5 will apply. That's okay.
Alana, that's a great point to lead into activity 4, which is going to ask you guys to think about some of the REAIM constructs as applies to your project. So now you know you don't have to use them all. You can pick the ones you want, and we're just going to, for reference sake, have them up here for you, and they're also in your resource sheet. I'm going to give you guys 15 minutes for activity 4. right, everyone. It is time for circling back to our example projects where we'll apply the REAIM framework to our 2 examples. So I'll give it away to Cindy again.
Hey, y'all. It's me again. This part should be quick because I think the previous speakers did such a great job setting us up to understand REAIM that what we're going to do now, hopefully, won't come as a surprise. So we were asked, what methods and metrics can we use to measure a few of the REAIM constructs for the thing you want to implement? And I believe the worksheet said we had to choose reach and effectiveness as 2 of ours. So reach, you've seen this before. Compared to our historic averages, have we, 1, increased the total number of inpatients referred for clinically appropriate genetic testing or counseling, and 2, increased the proportion of referred inpatients actually that have their clinically indicated genetic testing. And we were asked how we're supposed to measure it, so that's straightforward. That's a test of proportions. I can do that. And then it occurs to me we might also want to collect some qualitative data here too. So some of our stakeholder interviews, some questionnaires that we talked about before, and potentially participant interviews. For effectiveness, still struggling with this outcome a little, but I think the question we wanted to answer was, does inpatient genetic testing with post-test counseling lead to better patient medical and no worse educational outcomes? That's how I framed it. So acceptable patient knowledge pretest, that's the knowledge subscale of the MMIC, scored in a standard way. Low decisional conflict regarding genetic testing decision, probably the SURE scale in real life. And then back to my time endpoint, decreased time to receive these clinically meaningful results for patients seen as inpatients compared to our historical averages. All right. And then the other issue I chose, the other part of the framework I chose was maintenance, because this will be a study that we have funding for 2 years. So we'll get it stood up, we'll evaluate it, but is it going to be what we do moving forward? And I thought that that was really important. So 6 months after project funding ends, although I'm not completely clear how we're going to measure all this once study funding has ended, so that's a little bit of a circular argument, but 6 months after project funding ends, is our service still using a post-test genetic counseling model to manage cardiac testing and counseling of inpatients? If so, for what indications, for which patients? Has the number of patients increased, decreased, or stayed the same? Has the proportion of referred patients having testing increased, decreased, or stayed the same? And are we still using the video to assist in inpatient genetics education? You can imagine us dropping the video and just moving forward into testing. And again, for what indications, for which patients, in which units. That's all I got for this framework discussion. On to Colleen.
Actually, I want to go off script for a second and just say, Barry, how much I loved your frankness and honesty. And that's part of why we intentionally included some very practical quality improvement speakers in this. And really, in many ways, this project I'm talking about is very much this. My clinical leadership might be like, no, we're doing this. And I'm like, okay, I'm going to go over here. And you want to know what about it? And I don't even know if I can get that data, but I'm going to try. I also appreciated it because I originally became implementation science curious because I was like, hey, that REAIM thing looks cool in that paper, kind of seems relevant to some stuff I'm doing. And I love a good framework or theory, like operationalizing constructs is one of my favorite things. Yes, I am a dork. Okay, so I'm gonna go through this really quick because you've already heard me say all these things. I just reorganized them into these 5 categories. And also after hearing Adam and Wendy and Barry's talk, I also started thinking, man, I probably could develop this further and more richly, especially some of the whys instead of just the whats. So you can see the metrics that I put in under reach. Are people actually getting the thing? For adoption, that's the big one is the GCs actually changing their counseling. Some of the implementation metrics we already talked about that I put under implementation in REAIM. Was the tool sent to folks? When the GCs changed their counseling, did they change it for all patients, and did they continue to do it over time? So what we might think of as GC adherence to the practice change. But then did they actually change it in the way we intended them to change it versus changing it in some other way, which would be the genetic counselor's fidelity to the practice change? This is a little repetitive with Cindy's, but hey, 6 months later, are these things still happening? I am fortunate that most of these metrics, as I've mentioned before, are already routinely collected in our system. I have, wonderful analytics support where someone can just create a fancy dashboard for me in clinical to monitor this, which is really nice. So we have the capability to do that. But I certainly think this is the kind of thing where there's potential for drift over time, especially if we start to pull some of what I now understand to be implementation strategies that are supporting the GCs and making the practice change. Also, the GC's context changes often and a lot. We're very rapid moving practice. So I have a lot of reasons to think there could be threats to maintenance. So I'm particularly interested in that. Okay.
All right. So, switching gears to our next set of speakers, Alana Kolchak-Ram is going to be talking about implementation science approaches to address equity in genetic counseling. Alana is a licensed and certified genetic counselor with over 20 years focusing on the implementation of precision health and genomics within healthcare systems, including implementation of universal Lynch syndrome screening. Side note, it's not universal, it's tumor screening of certain tumors. So I would like to propose we get rid of the term universal forevermore in this context. All right, back to the script. Lynch syndrome tumor screening for certain tumors. Alternate service.
I'm with you on that. That's okay.
I don't like the term alternate service delivery models either, because they're not like we are delivering services and I don't know that any of them are alternate. We're just doing the best we can, guys. Okay. So she studies Lynch syndrome tumor screening, genetic counseling service delivery, and patient and provider understanding of genomics, as well as patient engagement. Thanks, Alana.
All right. I'll go with Miranda on all of those things. I do agree. I mean, I started this long ago when cancer counseling was alternate or, non-traditional genetic counseling, and now it's as traditional as it gets, right? So what did I just do? Okay, I will use the mouse. Okay, so I have no disclosures other than this is the work I do all the time. I'm funded by NIH to do it through my grants and stuff. So, but other than that, I have no conflicts of interest. And I'm really not going to tell you anything you haven't heard already. My goal really right now is we're just kind of, I feel like I'm really just kind of connecting the dots for you right here. Just to, as a friend of mine used to always say, repetition is the key to adult learning. So we're just going to present it in a little different way, but you have heard all of this already, even today, and I'm sure it's something you sort of innately understand. So, and that is the importance of why we need to think about equity, and Catherine brought it up in her presentation. You've heard it in all of these, but we all know the real world is messy. So there is no heterogeneity in our patients, in our clients, in our health systems. And so equitable benefit, we talk about requiring equitable implementation, but that doesn't mean that we have to find the one solution for everyone. There is no one solution for everyone. I think we all know this instinctively as genetic counselors. But again, that's where implementation science and one of the reasons why I think this is so important. And it helps us with the structural, societal, and other multi-level factors that can impact implementation. Those things can exacerbate inequities when they're not identified and addressed. We can also use it to look at, again, we talk about what works for who, when, and under what conditions, and maybe what you found is something that works really well for some group in some conditions but actually doesn't exacerbate inequities or actually overcomes them. You think about what Catherine showed you and how she broke it down by where in the point of care did you actually see the drop off, or did she see the inequity show up? So that was, we can do that with these methods. And so that's how implementation science can help, but it can also help in terms of thinking across the spectrum, whether you are trying to figure out what do I do, whether you're trying to figure out how do I evaluate it, what I implemented or what got implemented and now I'm coming in on the back end. But we can talk about co-creation with those who will benefit the most. Engagement, as I said, across the spectrum of your stakeholders, your target audience, those who you intended to benefit, be they clinicians, be they patients, whoever. And really the point to also help mitigate biases that we already know exist from big data. How can we help do that? And some of the components and ways that we do this are across all of these things we've talked about already today. Stakeholder engagement, models and frameworks, our evaluation approaches, developing, selecting, and adapting our evidence-based practices, or loosely defined evidence-based practices, or whatever leadership says we have to implement to change, to fix a clinical problem, as well as our implementation strategies. So engagement, of course, speaking to the inclusion of those from the communities who will benefit the most, and ensuring alignment either with the community or alignment with the clinicians, with the workflows, all of those different types of things, using our models and frameworks to find the one that fits. We saw a couple of times, even though we talked about re-aim, and I'm going to talk about it again, that all models are wrong, but they're all useful. It's okay if one doesn't fit, try a different one, as long as it helps you think through all of these things. And again, using the implementation strategies that fit your community, that fit the clinicians, the clinical context that you're implementing it in. And all of this can be seen, I want to point out to so Caitlin here, one of these resources is from a very brand new article that was just published in the American Journal of Public Health on the taking an implementation science framework and an anti-racism lens. So something very useful for us, even in our genetic counseling and what's important to us now. Turning this to the re-aim framework, which is also published by Rachel Shelton a few years ago as well, she gives some really good guidance on how to think about equity and promote equity using re-aim, regardless of whether you're using it as an evaluation framework or to help in pre-planning and everything. And again, we've already talked about these things. But this is just really reiterating how we use this framework as an example for how we can use any of the others to bring in that equity focus and ensuring that we're helping those that we intend to benefit the most and get the benefit that we want, that we're trying to help them get, and not exacerbate any inequities. So in REACH, we can talk about not just measuring who did we reach in the proportion, but are they reached equitably? Who wasn't reached and why, right? And then in terms of effectiveness, was the health impact equitably experienced? Because maybe it wasn't, or maybe we have found a group that did experience it better than the others. Do certain groups experience higher burden or negative effect, or the converse? Do they experience better outcomes? And why? In terms of adoption, implementation, and maintenance, the same thing. Again, these are things you've already heard, but just putting it in this equity thinking. So thinking of adoption, which is, reach at the setting and clinician level,
were low resource settings able to adopt the same as the higher resource settings? We had a couple folks talk about that already. What adaptations were being needed for to facilitate adoption in differently resourced settings or settings serving different populations? Implementation, who didn't deliver the intervention, the thing, and why didn't they deliver it? Was it a perception of, oh, my population doesn't want it? Or was it something based on information that they know from their practice? Did they have the capacity or the resources to implement or not? And then with maintenance, is it equitably maintained? And if not, why not? And by whom is it maintained? Are the long-term outcomes themselves equitably experienced, either at the patient level or the system clinician level? And do all settings have that capacity or the resources to maintain it as needed over time? So I want to go back to our implementation science in a nutshell, but add that you saw with Debbie, but adding the equity thinking on that. So what is the thing that's, did you co-create it, or can you co-create it, or how was it not co-created or not working with your intended population, the stakeholders? Does it work? Are the benefits experienced equitably? Why and why not? How do you need to adapt the strategies for different places and settings and people? And can all the clinicians or settings do the thing the same? And if not, why not? And how do you make a difference to help that? So now we're going to see an example of that.
All right, our next Q&A is going to be after this next talk. So if you have questions about what Alana presented or have questions about what Guan is about to present, then we will have an opportunity for that immediately following this talk. Yue Guan is up next. Guan is a genetic counselor and research assistant professor in the Department of Behavioral, Social, and Health Education Sciences at Emory University, Rollins School of Public Health. She also co-directs the Emory Precision Public Health Research Program.
Okay, so my charge is to talk about how we can incorporate or tend to DEIJ concerns in implementation science. So this is a very broad topic. Very, I know. But as Alana mentioned, and also as you can see from the framework proposed by Dr. Shelton, if we really want to achieve health equity, we really need to have anti-racism lens applied across all core elements of implementation research. So for today, I want to highlight one case example in the area of stakeholder engagement, because we know for stakeholder engagement or community engagement is very important throughout the implementation process, pre, during, and after we implement any health promotion programs. And also we know the importance of community engagement as recognized by many genomic research initiatives and policies. However, recent scoping review showed that only 1/3 of genomic research projects have ever reported the involvement of communities. And as you can see here, the extent to which communities are engaged varied a lot. So for today, I will highlight one specific community engagement strategy, which is on the higher end of the engagement. The method is called deliberative democracy. Has anyone familiar or heard about this term? Great. So another term, another way to call it is citizen jury. So very similar to a jury duty. Participants in deliberations, they will first learn knowledge of different and sometimes very controversial, very different viewpoints from experts. And then they will deliberate with their peers about the trade-offs. And in the end, they will come to a consensus. So the consensus will, the goal is to maximize what would be the best for the common good for their community at large, rather than their individual perspectives or interests. So that's the key difference from between this method with focus groups or other community engagement strategies. And this method, I want to emphasize, it's very useful in genomics research because the topic about genomics is always very complicated and unfamiliar to most of our target communities. And also, sometimes there are a lot of controversials involved. And a lot of times, the resources are very limited, so we have to consider the common good. So when you think about your own research and practice, you can think about if this method could be applicable in your setting and your target population. So I want to mention a little bit about the background of our program. So in the state of Georgia, since 2012, the state has implemented a family history screening program for BRCA-associated cancers across all public health clinics in the state. As you can see here from the map, the program has been very successful. Over the past 10 years, it reached more than half of all counties in Georgia and screened more than 30,000 women. And over half of them self-identified to be a racial ethnic minority. Despite these successes, the program reach, as we discussed earlier, has been very low, especially among rural and ethnic racial minority groups. So a reasonable question we could ask is, before we implement any program, should we put more and targeted efforts among this community, in our case, Black communities in Southwest Georgia? The obvious answer may seem to be yes. However, if we consider all the practical considerations and scientific complexities, all of these issues would warrant further community deliberation. So we designed our deliberation with Southwest Georgia Black communities and with these key deliberation principles in mind. One, we want to foster a very diverse viewpoints represented from the community, and we want to present balanced and persuasive information. So we are not trying to say family history screening is the best thing, the right thing to do, or genetic testing is definitely the right approach. We want to present both pros and cons and let the community to deliberate what would be the best for them. And also, a high-quality deliberation will require equal participation from all participants and the adoption of a societal perspective, reasoned justification of ideas, and also active engagement in understanding the very complex and analytical information. So all of these, the three principles were captured in our design of the three-step deliberation process. So first, participants, they will look at the video recordings from experts on topics related to BRCA-associated breast cancer, the genetic risk screening, and then they participated in facilitated discussions first with small groups and then with large group. And finally, they voted on the deliberation question if Georgia should have a more targeted screening approach among the Black community. So to optionalize these principles, for example, how to foster inclusive of diverse viewpoints, we developed a very complicated rubric. I want to highlight here is that in addition to screen for diversity of the common socioeconomic factors, we also want to assess participants their experience of civic engagement, which means their experience with community committees and if they have any experience voting in elections. Because we feel these indicators, to some extent, will show an individual's ability or experience to consider the common good or to deliberate, which is very important for high-quality deliberation. And also to develop very balanced expert testimonies, we went through a very rigorous progress. So you can see the key topics listed here. They're all relevant to the genetic risk screening process. But the main point, as I made earlier, was that we want to present both the pros and cons of a population-based approach. And also, like, in order to see if we have achieved a very informed and reasoned deliberation process, we conducted qualitative data analysis to look at using our audio recordings from the small deliberation groups. We want to assess these 3 indicators to see if we have achieved our goal, like if the discussion or the deliberation actually showed there were reasoned justification of ideas if participants really adopted a societal perspective. For example, a societal perspective would be indicated if participants made statements showing they had a group perspective, which was separated from their individual interests and perspectives. So this is one example quote when participants talking about the pros of having a more targeted approach. And regarding the deliberation outputs, as you can see here, we asked the participants to generate pros and cons. They generated as many cons as pros. So even though the pro has one overarching theme about saving lives, the cons were very diverse. So if we stop here, if we just look at the content analysis, we may make the assumption that this community, they may not be very supportive of a targeted approach. However, if we look at the voting results, we saw this group, they were highly in favor of a targeted approach, both before and after the deliberation. So I think one explanation could be, despite the many concerns they have, the participants, the pros of health and justice appeared to outweigh the many concerns they have when the participant had the chance to deliberate and consider all of this information in balance. So again, our sample size is very small and we just did it once, so we don't want to overinterpret our findings. But take-home messages, I think this approach is very time-consuming and labor-intensive, so it may not apply to all the settings. You really, regardless of the approach you choose, I think it's very important to think about the purpose of the stakeholder engagement, your timeline, and your budget. But still, I think these 5 points are worthy for us to consider when we choose how we want to engage our stakeholders. Okay, so that's, yeah, thank you.
All right, I don't see any questions online. Any questions for Alana and Guan? I feel tired too, guys. Yeah. Okay, next up is activity 5. I think this is our last activity for the day. So last round of facilitated experiences. I'm gonna put up another reference for you all. These are considerations that Alana presented about how to think about some of the constructs of the REAIM framework with the lens of equity. And then we'll see you all back here in about, I mean, you're not going anywhere. I'll be back here in, about 15 or 20 minutes to kick off the next round of example projects. And then we're gonna have a panel. So if you all have questions that you want to pose to our expert panel, you can submit them anytime between now and then. All right, off you go.
So we will stay for the entire conference or just today? I'm going to be in the entire conference. Oh, okay. What's it? Give me help. I'm like, I don't know if I changed that. So it's perfect though, thank you. Oh, but yeah, we definitely do. No, we're almost there. We're almost there.
1, 2, 3, 4. Too much.
Like the overhead carry. How do we want to do the back? Highly effective. Go get one-liner from them? Or we ask them to introduce themselves? Yeah, with a one-liner? All right. So we have made it to the last round of example research projects today. So I'm going to have Cindy and Colleen come back up for one last time to discuss how they applied Activity 5 to their own projects.
All right, guys, last round of the example research project. There's nothing on the screen, or not nothing, there's little on the screen you haven't seen before. So how will you know for whom the thing works? What data related to health equity can I include in my project? Well, this is relatively straightforward because, of course, we are going to pull from the electronic medical records, so we can pull a variety of demographic and clinical data from the EHR. And then how will I know for whom the thing works and does not work? You've seen this list of activities before. We talked about this before. At each step, I can track where there's leak in my funnel, and then I can do a stratified analysis by each of those demographic clinical variables to define for whom the thing works at each step. I don't know why, but I know who, and I know which step, or I will know which step. Moving on to the re-aim constructs, the text here in blue is the new thing. So for reach, just said we'll do the stratified analysis. So particularly the question then is, did the following differ by race, gender, age, diagnosis, insurance status, and zip code? So for instance, compared to historic averages, have we increased the total number of inpatients referred for clinically appropriate genetic testing and counseling? And if so, for whom? Also, pulling in those qualitative interview studies we talked about before can certainly have an element of assessing why certain subgroups of patients were reached and not reached. For example, referred and not referred. And certainly the participant interviews will help us understand, who chose genetic testing and why, who came actually for genetic counseling and why. For the re-aim constructs I used in Activity 4, how will I know if my thing is implemented equitably using the effectiveness module? So again, I was focused on figuring out whether there was acceptable patient knowledge, low decisional conflict. Again, those can be subjected to stratified analyses for all of the demographic and clinical parameters. And finally, as I said before, I focused on maintenance. And I think this is actually a particularly interesting question because I'm imagining as we figure out, is our service still using this post-test genetic counseling model to manage cascade testing in inpatient? The answer could be purely no. If it's yes, I think there's a lot to be done on if so, for what indications and why. And again, that is partly a quantitative analysis as well as qualitative analysis from stakeholder interviews. So these questions worked nicely for my research brain. And I think that, for me, was a relatively straightforward part of this. Over to Colleen.
Okay, so what about for my project? So again, we are purely leveraging what we routinely collect. So we have race, ethnicity. We can get a estimate of SES and rurality by using the patient zip code. We have gender, we have age, and we also have LGBTQIA+ identities, which I'm grateful to have some of those things that are sometimes harder to get. Which outcomes, I could kind of list all of them, but, and you've seen me put them up already, but in particular things like change in knowledge or post-tool knowledge, who's getting the tool, who's actually starting the tool, who's completing the tool. So then thinking about it through a re-aim lens, I'm just going to use two of the constructs, reach and implementation. So looking at reach with a health equity lens. So the uptake rate of digital tool among patients, much like Cindy just said, doing a stratified analysis, does this differ by race, age, sex, et cetera, the other health equity variables that I have access to? And then the same kind of analysis again for completion of the digital tool. And then if we see differences based on any of those variables, for example, you've heard a couple stories today about variables like this differing by race. We then want to dig into why. So could we do some interviews of patients who belonged to that group and had a lower, whichever group had a lower uptake or completion rate, to try and get some understanding and insight into why they didn't start the tool or why they didn't complete the tool. We also could, and this is actually something, speaking of, quality improvement and resource constraints and having to kind of do what you're already, rely on what you already are doing. We actually have our product team who has developed in collaboration with genetic counselors this digital tool and continues to iterate on it. And there are some folks there who have great experience in user research, including like sitting people down and doing things like think aloud interviews, which some of you may be familiar with. So there's some methodology that our product team already uses and existing outside vendors that we could pull on to, even with patients, not patients who were in this project, but patients who fit that demographic, where we could get some insights from them directly. So the other construct I picked is implementation. So in particular, for the GCs changing their counseling, did they change it consistently for all intended patients? So that idea of GC adherence, did that differ by any of my health equity or demographic variables? I think some of that the GCs might be aware of, and they could report to us in a meeting that we record or by us specifically interviewing them about this particular issue. I think we all know there's probably some of that we cannot, as humans, be aware we are doing. So we need a different set of methodology to get at that. One idea is to first just start with whether or not the session time, so for the people who got the thing, does the session time differ by any of those demographic variables? If it does, then we could dig in to see if there are differences in the way the counseling was modified that might explain that session time. And this is partly like being practical. I can't go listen to a ton of these recordings, right, to try and figure out, well, like, if I was doing this in a grant funded with more time kind of situation, we would probably do some qualitative coding of the recordings, or we would do some, content analysis or whatnot of a representative sample of these across different health equity variables. Can't do that realistically in this situation. So if I start with that, does the session time differ by these variables, and then have that point me towards certain recordings to listen to, that could be helpful. We could also check if the knowledge and decision-making variables, so the MMIC knowledge subscore and the SURE scale, differ based on any of these health equity or demographic variables, because that also could point to not just obviously that we have a health equity issue with the effectiveness of the tool, but also that could have led the GCs to provide different counseling, and it could explain why they did. And then, of course, we can also get some qualitative data with input from interviewing the GCs or the patients. So that's it. Miranda?
Okay, so we are going to shift gears to our panel, but before we get there, I would like to, I don't know if the session verification code was on the slide when you all were walking in, but I want to be sure that you all see that it's 2330 for today. So I'll leave this slide up for just a minute. While folks are snapping a picture, jotting a note of the verification code, I'd like to invite our panelists up. We have one microphone up here and 6 panelists, so we'll be passing the microphone around. Our panelists today are Adam, Alana, and Debbie, Rosie, Caitlin, and Megan. We are very excited about hearing their expertise in answering your questions. It may. I'm not. I'm just gonna do this. Yeah. So I was gonna say something. So we have one mic available for folks who want to come answer questions. I'm still seeing questions that come in through the electronic submission. You all won't be surprised that I jotted down my own questions throughout the day. So using the learning opportunity, and Colleen's moving the mic to the middle of the room, which is great. So I have been implementation science adjacent for a long time because I work at Geisinger. And it's really fun to see how everybody today has applied implementation science. I think it's been really relatable. We did the thing. Now what do we do? How do we use implementation science to study the thing? We started writing a grant and never finished it. We finished writing a grant and it didn't get funded. We could think about our context using a different framework or a different lens, and all of those things I think have been discussed and addressed today. The first question that I want to pitch to the panel is, while REAIM is great, are there other frameworks that you've found work particularly well in the genetic or genetic counseling context? And I'll say, I assume the answer is yes, because I've seen some of your work that uses frameworks without REAIM. So curious how you guys approach answering this question.
Yeah, I can recognize it.
Also, I didn't give Caitlin, Megan, and Rosie an opportunity to introduce themselves. So maybe why don't we start there? And then once you've introduced yourselves, one of you can take first swing at answering the question.
All right. Hi, everyone. My name is Caitlin Allen. I am assistant professor at the Medical University of South Carolina in Charleston. And I am not a genetic counselor. I call myself a doctor, but not one that helps anyone. So I would say just that it's really wonderful and cool to be in a room where you all as practitioners and clinicians and researchers yourselves are thinking about implementation science. It would be so fantastic to work with genetic counselors that think in this way. So I would encourage, as a big takeaway from this, if you have faculty or research groups within your systems or organizations, like, we want to work with you all. So that's just been a really nice piece of today for me. So my favorite additional frameworks aside from REAIM, I usually think of REAIM as very much an evaluation or outcomes framework. And there are many other frameworks that are thinking about determinants or what kind of goes into making a program successful. So Consolidated Framework for Implementation Research is one of those. I think that the most practical tool that I use is the Implementation Research Logic Model. It's a paper that was published in Implementation Science Communication by Smith et al. In 2020. That's how much I cite it. It's really nice for a grant application. It's really nice for sort of bringing a team together and walking through the different steps of your project. And it gives ideas of what pieces and parts of frameworks you could use to sort of build out your program. So that's my favorite, Implementation Research Logic Model.
You didn't make up that it was Smith at all.
No.
Okay, it's really Smith, guys.
Great. Hi, everyone. I'm Rosie O'Shea. I'm an adjunct assistant professor at Trinity College Dublin in Ireland and principal genetic counsellor of a cancer genetic service there as well. I came upon implementation science through my PhD, which I did in the University of Sydney in Australia, looking at implementing genomic testing in the oncology setting out there. So I think for many years practicing, I always wanted to make change in practice, didn't quite know how to do that on a kind of a large scale. You make small changes. And I think implementation science for me is really valuable in thinking about how to do that systematically, how to ensure that you're changing your system through, I suppose, a robust scientific way so that you can prove the effectiveness of what you're doing for your patient population, but also for the health system, and kind of scaling that up as well when it comes to moving your pilot study into something bigger. For me, I think I would have to agree with Caitlin. I would use CIPHER quite a lot, and thinking about how CIPHER has informed genomic medicine implementation. That's been one of the foundational kind of implementation science framework that informed GIMR, which is the Genomic Medicine Implementation Research Framework, if I've got that right. And I've used those two quite a lot in how I frame what I'm doing and how I ensure that I'm measuring outcomes that are pertinent to genomics implementation when it comes to looking at our health systems. But yeah, good.
Can everyone hear me okay? Okay, great. So I'm Megan Roberts. I'm an assistant professor at the University of North Carolina, and I'm at the School of Pharmacy, but I'm not a pharmacist. I'm an implementation scientist with an interest in how we can use tools from the field to improve the equitable implementation of genomic medicine. And in terms of frameworks, I think it really sort of depends. I also find myself using the consolidated framework for implementation research a lot, particularly when I'm trying to understand contextual factors that might be really important for the planning phase of a new implementation project. One thing that I'll note is, and another reason why I like CIPHER, and this also is the case with REAIM as we saw, but there's, I think, increasingly some integration between some of these implementation science frameworks and health equity frameworks, which I really like. The CIPHER 2.0 includes some health equity related constructs, and CIPHER has also been adapted for low and middle income countries if you do global health research. And then the final thing I'll just say is, and Alana alluded to this earlier, often I find myself using more than one framework in the work that I do, because usually one is not enough. When I use CIPHER, I often supplement it with an individual level behavior framework. I often use the integrated behavioral model. So yeah, there are lots of opportunities to mix and match and adapt.
All right, so the rest of us that don't use CIPHER and PRISM hasn't been named yet, but I happen to know there's another framework called PRISM. We've got REAIM. We've got the genomic medicine implementation. What's the acronym?
GIMR. I call it
GIMR. Okay, so we've got CIPHER and GIMR and REAIM and PRISM. And how do we, how those of us who don't have PhDs in implementation science, how do we pick what one to use? How do we know where to start, especially if you're saying maybe we should use more than one? How do we figure this out? Alana.
It depends. I was going to give Debbie or Adam a chance to. Okay. You pick the one that works. You try it on. I was telling one of the tables this. We spent one time. I wanted to use REAIM PRISM, so REAIM and PRISM sort of go together. And now, if you go to the reaim.org website, REAIM and PRISM are really being put together. And there is a tool on how to use it, by the way, too. And so it can be really helpful. But Bound and Determined, we really thought REAIM PRISM would fit because PRISM very much came out of quality improvement literature. The person who created it was a quality improvement medical doctor. And so we were convinced it was going to fit, and we just kept trying and kept trying and kept trying. And at the 11th hour in an grant application, we were just still struggling at defining our outcomes and went, maybe it's not us, maybe it's the framework. And we switched to colloquially what we call the Proctor model. Its actual acronym is the Consolidated Model for Implementation Research, I think. Conceptual, CMIR. So CIPHER, CMIR, anyway, it's the Proctor model from Enola Proctor. And that was the one that actually that Debbie showed with the, how we usually do research and how we do implementation research. It's that model. And I find that one actually works a lot really well for me when we're doing like primary implementation.
So Alana's practical advice, try it on for size, and if it doesn't fit, try a new one.
Yes.
Caitlin, did you have something to add?
I'll let Adam go.
Just really quickly, the conceptual model Alana mentioned is pretty intuitive as well. So it's a nice gateway drug of sorts for those who are kind of implementation curious. So I find that one, you can see the constructs, those are the ones that we think about clinically, and you have a sense of how you might measure each one relatively quickly as you're using it. So I think that's a good one to try on for size first.
Caitlin, before I pass it back to you, Adam, can I follow up with a question that I think relates to what you were just saying? How do you suggest a clinical GC gets started with implementation science? We've covered a lot today. Where do I start?
I think where any project starts, which is really defining what your question is. What is it that you're trying to determine? And then some of these other things that we've been sorting out today, really, what's the thing? And then what do you want to know about that thing? So really articulating those particular questions, that's a good starting place for anything that you're going to do for evaluating it. And I think we've talked through some more things than we normally think about: where, when, who, those sorts of things that we don't always think of in research. But again, really being clear about what it is that you're doing and what it is that you want to know before you think about any frameworks whatsoever. But just articulating those particular elements is a good place to start. And then you can determine, well, what resources do I have here? How can I really address this question? How much can I bite off to chew, and so forth? Then you can start getting into it. But starting with what is it that I'm trying to understand and what are the elements of it is a good place.
Caitlin, anything to add about frameworks, picking frameworks, or how to get started?
Yeah, I was going to say something very similar to what Adam did, which is I think using the tools that we had today, right? What was nice about today is that you started with the problem, right? And then articulated some of the outcomes you were interested in before ever hearing the words re-aim or hearing, so thinking about it in just layman's term, because we often can be very jargon filled in all of our own disciplines, and then sort of mapping those ideas that you have and concepts or things you're interested in evaluating onto some of the theories, models, and frameworks.
Colleen.
I actually just had an administrative thing. You might have said this, Miranda, but my brain is so dead that I lost it. For folks who don't still have the How to Submit Your Questions website up from when we showed the QR at the beginning, I just want to make sure you know that this QR code on your table, everyone has one of these on your table, you can scan it and get to the How to Submit Your Questions thing. And you can also vote up or down. So, hey, maybe you're too brain dead like me to submit a question, but you're like, oh no, I really want to make sure they talk about that one. So you can click the thumbs up.
So just, I have a question which, like so much else today, is probably going to show my ignorance, but we've heard a lot about cancer studies today. And I talked a little bit about cardiology studies today. Is there something I'm missing? Is there something inherent to cancer genetic counseling research that makes it better suited to implementation science than a standard general genetics clinic or a prenatal setting? Is there something more that I'm not seeing, or is there a funding story? Why?
I'm going to add on. I'm going to tag on. This is going to end up a two-part double-barreled question for you all. So in addition to, is there something about cancer and why? I'm going to add from online, are there particular areas of genetic counseling that would really benefit from an implementation science publication, for example, to support the federal effort? So why has everything been so focused on cancer? And if it's not because there's something particular about cancer, because I'm going to guess you say there's not, because none of these frameworks started with the cancer genetic counseling framework. What else should we be studying? Thanks for laughing, Colleen.
I'll start. I agree. Most of the research has been targeted at cardiac and hereditary cancer. And I wonder, is it because outside of the genetics hereditary realm, the outcomes for cancer patients or cardiac patients are very well defined? Maybe, I don't know. I thought about that when I was doing my research. How come there isn't more in relation to pediatric care. So I'm involved in one study with collaborations in Sydney, looking at, I suppose, mainstreaming now. There is funding testing for pediatric patients through doing whole genome sequencing. Neurology patients, similar in every country, it's being rolled out into the mainstream. But now they're looking at what are the implementation factors within those realms that will allow us to ensure that that is defined well, the outcomes are measured, and using implementation science in that way. And I wondered, in doing that work, it's looking at MGTs, looking at those interventions, looking at upskilling all the other clinicians, and they're learning from the cardiac and hereditary realm to ensure that they're adopting similar kind of implementation strategies to fit in ways with these other contexts, but perhaps they don't fit because the contexts are quite different, especially when it comes to the pediatric genomic testing. So I think maybe the outcomes are just not as well defined in genomics in other, if you think about pediatric, what are the interventions that are being given to those patients that allow a better patient outcome in the long term, whereas in cancer care and cardiac care, those outcomes are kind of more defined. So I don't know. I in that work with those team members, they're finding it very difficult to define the outcome, the end goal outcomes. And so we're spending longer trying to define the end goal outcome of the implementation strategies that we're trying to assess.
Other thoughts?
Yeah, there definitely is more heterogeneity when we're talking about things like pediatrics and even prenatal. I think there's more heterogeneity, and that can be harder. It may be funding, I'm not sure. It may be the interests. Just in general, I think we've had more cancer counselors do research than other types of counselors.
And I wonder if it's a time thing for maybe pediatric genetic counselors and prenatal or other types of genetic counselors. It could be a perception thing of, hey, it was implemented, this test just came down, and guess what? All of a sudden, everybody's using it. I don't really have a choice. There could be lots of reasons.
One thing to learn from the cancer setting, though, is that a lot of the work there starts with a guideline and whether that guideline has been implemented. So you've got NCCN in the cancer setting, but you've got referral guidelines for lots and lots of different subspecialties in genetics. So you can start there. Who should be getting this care based on what's recommended? And that's a way to apply the thinking to some of the other places as well. Exome and genome, first-line test in certain indications and so forth. So is that happening? You can kind of get to that fairly quickly. Is the protocol for Huntington being followed? What's the fidelity to that protocol in different types of providers? You can kind of, when there's a thing to do that's a recommended thing to do, which is the case for pretty much every specialty, then you can start to bring some of these tools to understanding whether it's been done.
So are there places, to circle back to the other question, are there places where you all see a need for more implementation science in genetic counseling? And do you want to elucidate some of those?
Yes, I definitely think there are. One of my students is going to start looking at some of the heterogeneity across pediatric genetic counseling settings, having to do with, how many patients do they see and what is the burnout, and how does that maybe relate to some of the contextual factors like what's the ratio of geneticists and genetic counselors and GC assistants, and what is their workflow, and can we start finding any sorts of patterns that might help us understand all of these complex things that go on in peds clinics.
Mm-hmm. I think to add some of the funding from a research perspective, some of the funding has very heavily for implementation science type of work has come from the National Cancer Institute, right? So just very practically, the National Cancer Institute has really focused on implementation science resources and capacity building for quite some time and been a leader in that space. I also think the National Heart, Lung, and Blood Institute is starting to take up this implementation science work. And so we'll hopefully see more in that space. Of course, the National Human Genome Research Institute as well. So I think part of it is funding for this type of work. And I would say as far as where, I mean, I'm not a genetic counselor, so it's really up to the genetic counseling community to say this is the next place to go. But one of the things that we talked about a little earlier was like, at what point is something evidence-based enough to implement? And so I think that's another potential opportunity is like, if there are things that are close but not quite guideline ready, or that we're sort of thinking about as being almost to the point of being in the evidence-based practice, can we start to build in some implementation science studies to both assess some of the effectiveness and efficacy outcomes and implementation at the same time?
One of the things that hasn't come up at all is the whole idea of de-implementation of things that are not evidence-based or when guidelines have changed. And I think there's a huge realm to do that in genomics, just because everything goes straight to clinic. And then we sort out, is this valuable or not? And I think that's a big area.
That is next year's pre-con. So circling back around, I've got one more question I want to ask about frameworks, and then I'm going to change topics. So at least for now, unless more framework questions, I can come back, guys, if you have more framework questions. But for now, one more frameworks, and then we're switching topics. Are there any online tools or resources that can assist newcomers in implementation science in selecting a framework and carrying out analysis? So what resources would you point people to?
Yes, and hopefully we have them in our resources list. Maybe not. The one where the strategies came from was the Washington University Implementation Science. That one is really good, really straightforward. Like, what are you trying to do? Where do you go? There's also the implementation science tool that is all the frameworks. What are you trying to do? And walks you through that. The ReAIM website walks you through using ReAIM. The CIFR website walks you through using CIFR. It has interview questions, so you can like design your own interview guide based on the CIFR in their website. So that's a good point. If we haven't had it in the resources, we should include those.
So there are references in the resources, but I don't know if there are like those websites for like additional looking.
I have one more suggestion.
I think they're in some of the slides.
Oh, yeah. So I know for me, when I'm thinking about frameworks, I think kind of going back to what Adam said, a lot of it has to do with like what is it that you're trying to do? What's the implementation challenge that you're thinking about? And there's a paper by Nielsen from 2015 where he talks about the different implementation science frameworks and breaks them down into buckets. And so I think sort of stepping back, sometimes a helpful place can be, what am I trying to do? Am I trying to implement something new? Because then I might want to use a process model, because that'll give me a step-by-step sort of process for thinking about implementation. Or am I really in need of a determinants framework, because I need to understand what potential barriers and facilitators are for implementation. Those are the determinants frameworks, which consist of classic theories and implementation theories as well. And then sort of that final bucket is evaluation framework. So if I'm evaluating the implementation of something, I'm going to start looking at that category of frameworks.
And that's where ReAIM falls, is that last category.
Exactly. Yeah.
I feel like that was
false. We will argue that ReAIM can be used across the spectrum, but typically it works really well for evaluation, and usually gets lumped there thanks to the Nielsen paper.
I think what I just heard was a framework for thinking about the frameworks.
Exactly.
So we're now in like implementation science heaven. I don't know.
The Washington University website actually does walk you through that exact thing, all the buckets based on the Nielsen paper.
Okay, so I promised a topic change. Debbie, I'm going to pitch this one to you first. We've talked a little bit about providing evidence-based practice, and how do you know when something has enough evidence to become an evidence-based practice and then studied with implementation science. But one participant asked, how does implementation science work in providing more evidence-based practice in educational approaches for training genetic counselors?
Okay. I might need a minute to think about that. And I am in the education of genetic counseling students. And I mean, I don't think that we've done a great job at pulling in enough evidence for what we're teaching. But is that where you're getting at? Maybe we need to do more of that? Maybe I'm not clear on where the question is going. I've tried to pull from all sorts of different disciplines in terms of finding evidence for what works in just patient-centered communication and trying to pull from a lot of different areas outside of genetic counseling and pulling that into some of my courses as these are evidence-based practices. I think we're getting better at it. I hear people talking about teach back now. Thank you, thank you. I hear people talking about values-based decision-making, and that decision-making and facilitating that is more than just telling patients, here are the pros and cons. What do you want to do? It's really facilitating that. And I think we've pulled some of that evidence in, but I do think we need more of that. I don't know how much is going on what's going on at all the programs.
Oh, I asked that question, Martha Dudek of Vanderbilt, and I think I was coming from the perspective of more maybe a challenge too, like how can like some of our, like the ABGC, the ACGC, and the genetic counseling program directors, how can we work better together in identifying ways that are more effective in training the workforce, especially as we're trying to scale up. And it seems like that is an area of opportunity.
So how do we use implementation science to study the way that we're teaching, training?
Yeah, and also like because we have somewhat moving targets with our standards and our competencies, and it seems like taking a step back from that might be helpful and getting a bigger picture. But
So I can't answer this in terms of genetic counseling programs, but I know at the School of Pharmacy at UNC, there's been an effort to try to integrate implementation science approaches and thinking to like curricular reform for the pharmacy education. And so I definitely think that's an area that's sort of cutting edge and has a lot of room for opportunity in thinking about how educational research and implementation science can blend.
And implementation science involves dissemination. So I have been fascinated to see how the different training approaches or different techniques. So motivational interviewing has diffused into several genetic counseling graduate programs. We haven't really studied that. We haven't really pushed hard to do that in a systematic way, but that's what implementation science is about, is to try to do some of that in a systematic way and not just rely on passive diffusion.
So I don't have a question, but I think in response to that question, so I can share one example what we have done at the Emory Genetic Counseling Training Program. So I teach one class during summertime called Public Health Genomics. So recently I kind of changed the curriculum and because a lot of genetic counseling students, they are interested for their thesis project, they want to improve patient access to care or improve patient some health outcomes. So I introduced the intervention mapping, like the 6 steps, and also introduced the pre-SAID model, logic model. So the assignment could be they can develop a very pilot program, applying these implementation science frameworks and the thinking, and with a goal to improve either quality improvement for a local institution or think about public health applications. So, but I know that it's not part of the core curriculum. I think that's a starting point for us to think about ways to incorporate that into our genetic counseling training.
All right. So let's say that this is one of my questions. I'm very pleased. Let's say that you've convinced us all to be excited about implementation science, and we've got our questions that we're asking, and we've defined our context, and we're excited about the framework that we've picked because it's re-aim, because that's what I did the worksheet on today. How can I start to think about getting my institution or department, or, I mean, I don't have to worry about this actually because I'm a Geisinger, but let's say I weren't. How would you recommend somebody to start thinking about how do I bring others along with me and get support for doing implementation science in my realm, whatever that realm might be?
I'm going to pass it off because we were talking earlier and I thought we had a great answer here.
Yeah, so hi everyone, I'm Anna. I work at Be the Match, or the National Marrow Donor Program in Implementation Science. And we were just talking about kind of selling this to leadership and kind of how I got my role in implementation science there. And I think it depends on who you're talking to and what their kind of interests are and the value that it brings. So when I'm talking to the research arm of the organization, how I talk about implementation science is very different than when I'm talking to executives or business leaders. And so I think there's value that it brings for both sides, but I think shifting how you talk about it and discuss that value depends on kind of who it is. So for the research, it's really around those evidence-based practices, and you're doing all this work, and let's make sure that it actually gets adopted and changes, outcomes for patients. And for the C-suite and the leaders, it's really around informed decision making and how do we, use our resources in the smartest ways and make informed decisions. So that's my take on it.
There was a thoughtful comment at our table along those lines, which is that the frameworks can actually help you determine which outcomes to emphasize to which leaders. So that'll guide what you choose to present, and think it might have a little better chance of being compelling in that situation.
I definitely agree as far as institutional level support, emphasizing certain things with different audiences. I would also say you can also just do a lot of this, right? Like a lot of these concepts are things that you're already thinking about and could be kind of pulling into more of a quality improvement type of space on your in the day-to-day work, right? And that in and of itself is helpful. And building evidence on sort of a smaller scale and then taking that example is also kind of another approach. So maybe both like top down and having those conversations, but also just by inherently doing it in day-to-day work, you're building a case that way as well.
Yeah, so sort of if you're already able to do some quality improvement study, in fact, I should pass it back to Miranda to talk about that. But, that is, and Debbie used the quote, if we want more evidence-based practice, we need more practice-based evidence. So what are you trying to show? Do you need to justify another genetic counselor? Do you need to justify having GCAs? Do you need to justify a new program to your leadership? If that is something that you can do and bring some of that in to both help your job better and to start the ball rolling, that can be a way to do this.
So one of our other questions, and if you guys have more questions, I'm running out of questions in the chat, which is fine because we're winding down for the day, but also this might be like a final call for submitted questions here. So one of the other questions in the chat is, can you say more about what it looks like to apply implementation science retrospectively? For example, when implementation science wasn't used and the change has already been made, which I think, Barry talked about having done that in the setting that was presented on earlier. I certainly did that when I was looking at the practice change of implementing genetic counseling assistants in our cancer clinic. So I think it happens pretty regularly that we implement something and then we're like, well, I want to see if it worked for whatever outcomes we're interested in. And we might have an idea of we were interested in access or genetic testing uptake or time till next appointment or cost to patients or whatever. Like there are all sorts of outcome measures, but how can we have something that's been already implemented and now we want to look at it with an implementation science lens?
So that's what happens a lot of the time. Sometimes things come down by leadership. Sometimes things come down by, tests get implemented, direct-to-consumer genetic testing all those years ago, NIPT, things like that. An example that Debbie was reminding me to talk about is we've done that. We looked at, I will not say universal Lynch syndrome screening, but tumor screening for Lynch syndrome. A decade after a decade after the guidelines had been out, and we still know people to this day, health systems that do not do it or do not do it well. And so it's not having the impact that we wanted it to have, and why not? And so we turned an implementation science approach to look actually across all of these different healthcare systems that are doing it. We know they're doing it differently and some not at all, and use the consolidated framework for implementation research to try to understand why, and to use a wonderful new tool that Debbie happens to be expert in now, the coincidence analysis, to really geek out over the data and be able to understand some of those difference makers. But the overall point was to say we really need to understand, yes, every site is different, but what are those similarities between those that can't implement it at all, those that can but aren't doing it well, so they're actually not really helping us because they're not having the health outcome, and so it's leading to clinicians and other people saying, we don't even see the value in doing this, and those that are doing it well. And you can think about that applies to a lot of different things we do in genetics, and a lot of different guidelines. They may not be implemented well or at all in different places, and no wonder we can't get any traction, right?
So maybe to summarize, it echoes a little bit what I think I heard Adam say earlier, which is if you want to do some research on what you've already implemented, think about what your research questions are. What do you want to know? And think about what resources do I have? How can I learn the things that I want to know?
Yeah, and I think there can be more cross centers comparing to each other. And I think we've learned a fair amount. That's part of why my student's going to look at across different pediatric centers and look for differences, similarities. Can we find any of these patterns that are associated? But that's after they've implemented whatever they've implemented. We don't even understand exactly what they've implemented. So now we have to go look at what they implemented, look at how it turned out, and see if we can find patterns.
So there's a question in the chat that I don't actually understand what this person's looking for. So if you want to come clarify, I'm going to read it because maybe somebody else's brain will understand what they're looking for. The question is, can anyone comment on PGX?
Pharmacogenomics?
Mm-hmm. That much I actually knew.
Got that. I am not a genetic counselor. There you go. You heard that.
But more the broad, can you comment? I don't know what direction they'd like you to comment.
Implementation of pharmacogenomics, I would imagine something along those lines.
I'm involved right now, and so is Megan, in a study looking at implementation of pharmacogenomics when it comes to psychiatric medications, antidepressants. And the question we had was, why do some providers go in gung-ho and adopt this and do it for everyone, and why do other providers not? And so this was a bunch of interviews with a bunch of providers, and I'm using the same analysis, and we found some difference makers, what seems to differentiate those that have adopted and those that have not adopted. That hasn't been published yet at this point, but that's one of the things that's going on in pharmacogenomic implementation science.
Cool. Okay, I want to wrap up with an opportunity. I'd love if everybody could answer this question, so we'll just pass the mic along. My final question for you all is, I'd love to hear more about something that you wish you'd known when you were starting out that you could share with us now that might help to guide our paths.
It's a great question.
Adam's ready. Oh, Megan's more ready.
Mine's just closer to me. Is this on? Yeah. So I don't know that this is so much advice as maybe some reassurance. I feel like it took learning about the implementation science jargon and learning about frameworks and outcomes multiple times before it ever really sunk in. And I remember in graduate school, I took an implementation science class from an amazing teacher. And at the end of the semester, I was like, I still don't think I really understand what implementation science is. And it really took sort of getting my feet wet and doing some research in the area before I really started to understand and wrap my mind around all of it. So if you leave today and you feel like, I still don't know if I really understand what implementation science is, feel reassured that that's okay. And it comes with time.
I still don't have my head wrapped around all of it, and I've been doing it for quite a while.
My lesson learned is probably the importance and value of involving stakeholders early on in all of the work we do. And I think, of course, there's in clinical settings, many different stakeholders to think about: patients, providers, other MAs, clinical staff. And then also, I think one thing that MUSC has really tried to do is involve community members through, Guan's example as well from the deliberative democracy, but just really getting that early feedback about the thing and about the strategies that you're trying to use for your program.
I'd say similarly that there are probably lots of other people at your institution who think like you think. In other words, about operations. So how do programs work? Why don't they work? Where do they work and for whom? Finding those people is critical. I didn't know exactly where to look and where they existed and so forth. So that's something that I think if you can get a kind of a cadre of like-minded people, even if they're in a completely different specialty, the tools are the same. And the types of lessons are still applicable. So finding those folks, I think, can really facilitate the furthering of the particular interventions that you're trying to move along.
One of the things that I now see, which I didn't see at the start, is, whatever you're implementing, what change you're making, thinking about the whole of the system and kind of stepping back from what you're doing and how it's linked in with some other context potentially. What I did was in cancer, but that could inform cardiac. So what you're doing with an implementation science framework and having that embedded helps to generalize those lessons in another setting. And I think that's really powerful when you think about learnings across disciplines and then thinking about your system as a whole. I now look at, I don't just think about my service, I think about how I fit in holistically with the health system and how what I do impacts, say, the emergency department or decision makers. I think it's really valuable to think from a whole of a systems approach when you, well, maybe not when you start out, but as you get into it.
And I would say on all of those, it's okay to just get started and to learn as you go and just practice while you're learning. It's a team science. You can find people who think the same, you can think system level, you can engage your people. It's something everybody said is learning. You're learning about everyone, you're learning about the system. So you're learning as you're doing. And that is what is one of the cores, I think, of implementation science. So it's okay to get started and learn while you're doing it too.
I still don't have a good answer for that, but I thought of one other thing that relates back to a prior question. One of the new competencies has to do with making sure genetic counselors know how they fit within the broader healthcare system. So that's really where we can tie in implementation science into our curriculum is, we need to understand context. And I think giving them a sense of this broader context can be helpful. I would just echo what everyone else has said. I think the pre-implementation work, like Caitlin was saying, is critical. I also agree that you don't have to know everything. I didn't know everything. I still think there was a review article, and I still think that they pointed out that I didn't use CFR in the right way or one of those things, right? So I get cited for doing something wrong, which is great. There we go. Now we learn.
It's published
And I would
there
say,
forever.
Yeah, so, and even a paper, this was a double-blinded review, meaning that the reviewers didn't know who the authors were, and a paper with Russ Glasgow, who created REAIM, was told that they were using REAIM wrong. So it is okay.
All right, I think that's a great place to wrap up. We're all gonna do it wrong. That's what I just heard. No, that's not what I just heard. Okay, so I have two more things that I wanna leave you with. First, a challenge. Alana alluded to I shouldn't say that 3 times fast. Alana alluded to some early research that I did at Geisinger related to implementation of GCAs in our cancer genetics clinic. I never once used the term implementation science in that paper. I did not know I was doing implementation science. It's totally implementation science. So I think that my challenge for everyone today is to, as you go through the conference, think about what posters, what talks, what presentations are using implementation science ideas without calling itself implementation science, without using one of these frameworks that we've talked about, and see if you can just have a little implementation antennae for looking for these kinds of projects throughout the rest of the conference. The final thing I'd like to leave you all with is I just want to take a minute to thank everybody that made this session possible. This has been a super fun afternoon. There's a small but mighty planning crew. Debbie, Alana, Adam, Cindy, Colleen, and Zach, and I were, thanks Colleen, and me, we're all involved in conceptualizing and bringing to fruition this pre-con. Colleen has been our fearless leader throughout, and all of the facilitators and all of the speakers and the consultants that agreed to come and share their expertise with us. It's been a really incredible afternoon. So I just want to take a minute to thank everybody.